9 घंटे चलती है। उस समय का क्या स्कूल में मॉनिटरिंग करने के लिए या पहले से परमिशन होता है या वायरल इन्फेक्शन, बैक्टीरियल इन्फेक्शन, इन्फेक्शन, इस टाइप चीजों की कौन सी दवाइयाँ कौन सी देनी चाहिए या कौन सी दवाइयाँ नहीं देना चाहिए, इसके विषय पर चर्चा की जाए। दूसरी बात वैक्सीनेशन को भी इंडिया प्रोड्यूसेस टिटनस और अभी तो कोविड की जैसा कि बताया गया है कि 2 महीने पहले बताया जाता है सेफ एंड प्रेगनेंसी इनएक्टिवेटेड वायरस है, ये टोटली सेफ एंड प्रेगनेंसी उसको ही कर सकता है। और जितने भी जो वैक्सीन को जाते हैं वो वैक्सीन होते हैं इम्यूनाइजेशन होता है, ये जो है बच्चे में पैसिव इम्यूनिटी पैदा करता है। साथ में एक्सरे के बारे में मैडम बताएंगे, एक्सरे भी अगर मदर की हालत नाजुक है अब एक्सरे करना आवश्यक है और एब्डोमिनल छीनने के बाद एक्सरे भी किया जा सकता है बच्चे को बचाने के लिए। यही सब चर्चा
good evening, everybody. It's a pleasure to invite you today on the 4th day of the 28th IMA CGP Kanpur. It's a great pleasure today. Our three program directors and the speakers who will be conducting this session. The first program, the first lecture is by Professor Sheila Snyder, who is senior professor in anesthesiology from Tata Memorial Hospital, Mumbai. The program director of which is Dr. Surya Gupta, who will be conducting this session. And I welcome you, Professor Sheila and Dr. Raju. So, welcome, and I hope you can listen to what we are doing. Thank you. Please come online, mute yourself, and then Dr. Sanjay Gupta will introduce you and introduce you.
Dr. Shaila Maitra is a senior professor head of medical care in Tata Memorial Hospital. I would like to invite my first chairperson, Dr. Aditya Shukla, senior executive at IMA Hospital. And I would like to invite my second chairperson, Dr. Sika Sachan. She is very timely, young, she is in University in IMA Hospital. And now Dr. Sika Sachan will explain and introduce my speaker.
Good evening, everyone, and welcome you to this session. It is a matter of great privilege for me to invite the esteemed speaker for this session. I'm happy to introduce to you Professor Sheila Naiman Maitra, who is professor from Department of Anesthesia and Critical Care, Tata Memorial Hospital, Mumbai. She is also the president-elect for ISCCM 2022. Madam is the president of the All India Difficult Airway Association and is a chair of the Intensive and Critical Care Medicine Committee of the World and also of the World of Federation Society of Anesthesiology. She has been appointed on Surviving Sepsis Campaign COVID Guidelines Committee and also on the committee of WHO Oxygen Algorithms for different resource settings through WHO. She is also a council member of the Asia Pacific Sepsis Alliance and is among the 14 international experts working on ASA, difficult airway and the PUMA guidelines. She has also developed a new test in hemodynamic monitoring called the Tidal Volume Challenge. Madam is also a member of the editorial board of various reputed international journals like Intensive Care Medicine, Anesthesia, Journal of Critical Care and Trends in Anesthesia and Critical Care and Airway. She has also been awarded with the Fellowship of Critical Care Medicine by the American College of Critical Care Medicine and also the FICCM by the Indian Society of Critical Care Medicine. She has also over more than 100 text publications and over 40 book chapters to her credit. And Madam, I invite you for beginning this session.
Good evening, everybody. Namaste. Greetings from the Tata Memorial Hospital in Mumbai. At the outset, I'd like to thank the organizing committee of the IMA College of General Practitioners, the organizing committee of the 38th refresher course that you are having. Thank you very much. It's indeed a great honor and a great pleasure to be here and to talk on a topic in which I'm doing a lot of work and a topic of my expertise and my interest. So today I will be talking to you about the role of high flow nasal cannula oxygen in moderate COVID. Uh, I just like to ask, can you hear me clearly and can you see my slides? If I can just get a response on that, I just want to be sure that you can hear me
Yes, yeah, I can hear.
and see my slides. Okay, thank you, sir. Thank you. Right. So, so I will be talking about high flow nasal cannula oxygen. And as you know, that over the last 2 years, we have been really troubled during the pandemic with this COVID 19. And even today, the cases are rising, and we are still learning as we are going along. I'm going to be talking to you about this therapy, which is a very simple therapy that was not used much early in the pandemic, but has really saved a lot of lives in India, especially during the second part, later months of the pandemic last year. So, I'm going to be talking about this form of non invasive therapy. And it's especially important for general practitioners because this is not like mechanical ventilation. It's not so complicated. It's quite simple to use. And it is, you can say, something like a bridge between just oxygen face mask versus tracheal intubation and mechanical ventilation. So, it is a higher level of support, something like a bridge, which can actually avoid tracheal intubation and mechanical ventilation in a lot of patients if it is applied at the right time and performed correctly. So I'd just like to highlight on this over the next 20 minutes. I will like to tell you firstly how this works, how the therapy works, and what is the concerns about using it in the in COVID-19 patients, and what is the evidence around using it, and how we can take this therapy forward to help us better in the future. So, just a little about non invasive respiratory support. Now, when you have a patient who comes to you with acute hypoxemic respiratory failure, before you intubate him, there are various levels of respiratory support that you can give. So, the common non invasive therapies that we know is one is, of course, face mask, the regular oxygen face mask. You can put this with a reservoir bag. Is say you can give more FiO2 to the patient, or you have non invasive ventilation where you have the patient spontaneously breathing and you can give some pressure support and PEEP. It's like a face mask covering the nose and the mouth. And this can give a higher level of support than non-invasive therapy. And now in the last 10 years, we have this therapy called high flow nasal oxygen. So this is, and I'll talk to you about the way the device is, but this is a little higher level of support where you're giving higher flows. Now, conventional wall oxygen that we use with the oxygen mask will give you something like up to 10 to 12 to 15 liters of oxygen. This has a special flow meter where you can give up to 60 liters, 60 to 70 liters of flow to the patient. And that is why you need a special flow meter for this. And you have a special nasal cannula for this delivery. And because you are giving dry oxygen to this patient, it will not be well tolerated. So this oxygen is first passed through a humidifier so that you can give heated humidified oxygen. So today I will be talking to you about this therapy and how you can use it in the respiratory support. And the beauty of this is that you don't need to use this in patients in the ICU alone. You can use it in ward patients on an OPD basis, and it is a little higher level of support than you can use with the conventional oxygen therapy. So, what is high flow nasal oxygen? Now, when we talk about high flow, we talk about flow more than 30 liters of oxygen. So, it's not less than 30 liters. You have to use a different flow meter, which can give you up from 30 to 70 liters. And we start with 30 liters of oxygen. Now, to give this therapy, there's a special nasal cannula. So it looks like the regular nasal cannula, but it's a separate disposable device that comes, and it is a very soft cannula that can be put, very comfortable, and this can be clamped to the patient. So this is the way the cannula. It comes with a disposable set, and it is very comfortable for the patient use. Now, as I mentioned, when you're saying high flow, you're giving 30 liters or more of oxygen. Now, a patient will not tolerate such high flow of dry oxygen because if you give dry oxygen at such high flow to the patient, it will be produce a lot of discomfort, and you can get epistaxis, and patient just will not be able to tolerate it. And that is the reason that we need to humidify this oxygen, and we cannot give dry oxygen at such high flows. So what happens is you have a wall flow meter, and you set that at 30 liters, you can go up to 70 liters, and then that oxygen goes through this humidifier, and then through this humidifier it gets warmed and humidified. You can set the temperature at this. I will tell you also about the temperature setting, and then it goes to the patient and it is delivered through this simple nasal cannula. Okay, so I will just tell you how this humidifier works. If I can, okay, I will just show you the setup of the machine. So this is what it looks like. You can just mount it on a simple, like an IV stand, very simple machine. And I will just, I don't know, hope the video plays. I will just show you how this humidifier is, you can see it over here, how it is set up and how it is used with the patient. Okay, so this is a simple device, how it looks. And this is where you fit it's called the Evo 2. And this is where in the front is where you can put this humidifier. And this humidifier is connected to the water bag. And here you can see the oxygen is coming in, and it also entrains air, right? So you can give different FiO2 value. It goes through the humidifier. Okay. So you get warmed, heated, humidified oxygen, which is delivered to the patient. You can see it goes through the humidifier, and depending upon what concentration, you don't have to do 100% oxygen. You can set it and it will enter in air, dilute with the oxygen, and give you the desired FiO2. So this is the way the machine and the entire contraption looks, as you can see in the now, I'd just like to show you how you can set this machine. Okay, how you can how you can do that. So regarding the setting, now there are only three settings that you can do. One is you can select the FiO2, you can select the temperature, and you can select the flow. Okay, see that these are three settings. Like I told you, you don't have to give 100% oxygen to this patient. So initially, when the patient comes, you will give 100% oxygen. But after some time, you will see that he gets comfortable. And then you can adjust the FiO2. You can bring down from 100%, say 80, 90, 60, 50. You can go down up to room air, different FiO2, depending upon what is your target saturation. And in COVID-19 patients, we are keeping the saturation somewhere above 90%. So you can adjust the FiO2. However, when the patient first comes, you give 100% FiO2, and then you can titrate it slowly. Regarding the flow, you start with 30 liters. Like I told you, a high flow nasal cannula oxygen therapy is flow more than 30 liters. So you start with 30 liters because patient will not tolerate. They get a little feeling of, tightness in the chest when you give such high flow. So first start with 30 liters, and then you go on increasing the flow to 40 liters, 50 liters. You can go up to 60 or 70 liters. And you will see that the patient who comes very breathless will start, the breathing will, respiratory rate will start coming down. Patient will start getting very comfortable. Work of breathing will decrease. Clinical signs of respiratory distress like nasal flaring or indrawing of the intercostal muscles, all this will start settling down when you start giving the high flow therapy. So as I mentioned, 100% oxygen in the beginning, but flow you start from 30 and you go on escalating. Now supposing you have come up to 60 flow and you see patient is now very comfortable, then you don't need to keep at 60 flow. You can come down to 50 flow. At 50 flow, if you see the patient is still comfortable, you can come down to 40 flow. And this is how the FiO2 and the flow is not set in parallel. FiO2 is set according to the target saturation that you want, oxygen saturation, and flow is set according to the patient comfort level, starting with a low flow of 30 and then going up to the maximum. And then depending upon how the patient tolerates and the decreased work of breathing, you can go on de-escalating the flow. So this is the way, just to tell you that the patient can be on a setting like he can be on 100 FiO2 and flow can be just 30, or patient can be on 21% oxygen and flow can be 60. So both these values do not move in parallel. And I will just show you how the machine is set. So this is the panel of that monitor. And as I told you, there are three settings. One is a temperature setting, there is a flow setting, And there is the FiO2 setting. So you can see this. What I'm showing you is a video from Fisher and Paykel that manufactures this device. It's called the Evo. And here you can see, just bear with me with the video. And you can see how the setting is done. As I mentioned, there are three different types of settings. There is a temperature, okay, there is a flow, and there is a FiO2 setting, right? So we start with the temperature. You select the temperature, and when you press both these buttons, it starts flashing. Once it starts flashing, you can either increase or decrease the temperature, and you have a range from 31 to 37. So you have to keep the temperature that is comfortable for the patient. We have set it at 34. Next, you come to the flow setting. Again, you press both these buttons, and you will see that the flow will start flashing. Flow can be set up to 60 liters. Okay. So you can say for this patient, suppose we are setting at 50 liters. Then you can, to change the FiO2, there's a flow meter like this. Okay. So this flow meter, you can go on increasing or decreasing. As I told you, this is not the regular flow meter. This is a flow meter with the flow going up to 70 liters of oxygen. So you can adjust this flow meter, and that way you can change the FiO2. So this is the way that you can set this, and after you can make the setting of the temperature, the flow, and the FiO2, then of course you have to lock the setting and attach the cannula on the patient's to the patient's nostril, and make sure that the patient is comfortable, and you can titrate the settings as I showed you before, as I explained to you before. So very, very simple device to use. You know, a technician can set this up. This doesn't need very complex, very complex technology or very complex, monitoring or even setting up. It is very, very, very extremely simple device. It's not like invasive mechanical ventilation. And what used to happen earlier is we used to, when a patient came desaturating with signs of respiratory distress, we would give them oxygen mask, and then when the patient will get more more uncomfortable, increased respiratory distress, straight away we would go into intubation. So this is something like a bridge between these two therapies, just like non-invasive ventilation, that is better tolerated by the patient, and you can actually avoid tracheal intubation in many patients by using this therapy. So basically, what are the advantages of the high flow? So this is what the patient he has. He doesn't have a tube in the mouth. He doesn't have a mask over the face. So this is a very comfortable therapy for the patient. Now, what is the advantage? Now, this can be used outside ICU, like I told you, ward, OPD level, it can be used. It is not like invasive mechanical ventilation. Very simple to set up. I showed you there are only three settings that are required. Okay. Very simple to use, to titrate. You can have even a technician setting this up. And that is why this has been very, very useful in COVID. Many hospitals, nursing homes, places have invested in this therapy, because this can avoid giving mechanical ventilation to this patient, and does not need very advanced monitoring. Simple and easy to monitor, and it's very comfortable for the patient. If you've used this therapy, you will see that the patient, and it's not only for COVID, but of course for non-COVID. A lot of people got their first experience in COVID patients, because a lot of hospitals, government invested in many, many of these machines. And now people have got very familiar with using them. So I'm sure many more people will use it in non-COVID patients. And it's very interesting. I'm sure some of you must have used it. For those who have not used it, when you use it, you will see a patient is comes so breathless to you, and you think chalo abhi ye to intubate ho jayega thodi der mein, and you will see gradually patient starts getting very, very comfortable. The respiratory rate of 50 will come down further, patient starts getting comfortable, saturation starts coming up, and this helps. Now what works is two things. One is the flow, the high flow that is being delivered, and this also flushes out the CO2. So it's like it reduces the work of breathing, reduces the respiratory distress. In addition to that, if the patient keeps the mouth closed, you can also get PEEP, and that is positive end expiratory pressure. And this PEEP helps to improve the oxygenation. Now, how do you get the positive end expiratory pressure? You are giving such a high flow of 30 liters to this patient, and patient is exhaling with the mouth closed against the resistance of 30 liters of flow coming in. And this generates positive end expiratory pressure. But what happens is if the patient keeps the mouth open, then the PEEP effect is lost. But even if the PEEP effect is lost, you get the high flow effect, which will reduce your work of breathing. But just a practical point I want to tell you, when you use this therapy, try to make ask the patient to keep the mouth closed. So it's very comfortable for the patient. Most importantly, patient can eat, patient can speak, and patient doesn't feel suffocated. Though, if you have seen patients on non-invasive ventilation, when they have the mask covering the nose and mouth, they feel very suffocated. They feel that, oh, I can't breathe, or some people just don't tolerate this therapy. So this is very comfortable. And if you ask any patient, he says, no, give me this, give me the cannula, don't give me the mask. And as I mentioned, it reduces the work of breathing. And most important clinical benefit is that you can actually avoid tracheal intubation in some patients. We all know that the mortality is high in those patients who receive invasive mechanical ventilation. So our goal should be to try to avoid tracheal intubation if it is possible. Not only because of that, but because we have limited ICU beds, limited ventilators. This kind of therapy can actually avoid patients going to the ICU or avoid patients going into the a ventilator, because once a patient is on mechanical ventilation, the manpower, the resources, the monitoring, everything that is required is much, much higher than a simple therapy like this. But a word of caution, you have to monitor this patient. You cannot say कि चलो अभी high flow पे डाल दिया तो सब काम हो गया. You have to monitor this patient. Now, if you are on the maximum support, that is 100% FiO2, and you are on 60 liters flow, and still the saturation is not maintained, saturation is not above 90, or you are seeing that the patient, clinically आप देख के समझ जाओगे, patient's respiratory rate is going up, or patient is having indrawing of respiratory muscles, sternomastoid, nasal flaring, despite being on the highest level of support, then you must intubate these patients. The mistake that people have made in COVID, if they've said, चलो high flow nasal cannula machine है, इस पे डाल दिया तो अभी कोई intubation की कोई ज़रूरत नहीं, ventilation की ज़रूरत नहीं, and patients have continued to be on this therapy. They should have been intubated. They did not get intubated at the right time, and this resulted in high mortality, high morbidity, and then they blame the machine. So it is not the machine, it is the man behind the machine that is as important as a machine. So the important message I want to tell you is that not only is it important to give this therapy, but you need to monitor the patient and make sure that he is comfortable. Another very acute problem we faced is oxygen shortage. So, if you're thinking about oxygen shortage, this may not be a very good device to use, but very important, you should reduce the flow when the patient is comfortable. Many units, when I went for inspection, they were on 60 liters flow. कोई ज़रूरत नहीं थी, 60 liters flow. Patient is comfortable, 50 कर दो, 40 कर दो, 30 कर दो, come down. So you don't need to give such high flow when the patient is comfortable. In the beginning, you might give it, but as the patient improves, as the respiratory distress subsides, you must reduce the flow, and this will help you conserve a lot of oxygen. So this is just how high flow, the machine is set up, how it works, and what are the advantages. Now, what is the role of high flow nasal cannula oxygen? And I will tell you in the pre-COVID era, just to tell you what is the evidence worldwide, what is the utility of this. And this was a very nice review article we published in Intensive Care Medicine last year. And this is a very nice picture which shows you three places where you can use high flow nasal cannula. One is, of course, like in COVID, in patient as an initial oxygenation strategy in patients who come with high flow in acute hypoxemic respiratory failure. Second is during tracheal intubation, you can use this therapy. And third is after invasive mechanical ventilation, after you extubate this patient, you can put the patient on high flow nasal cannula oxygen. So these are the three areas where you can use HFNO. What I am describing today is in patients who come in respiratory distress and you are using high flow nasal cannula. So we have, and this is, I'm telling you the evidence in non-COVID patients. So far, what literature and what evidence we have. So in non-COVID patients, both NIV and high flow nasal cannula oxygen are better than conventional oxygen therapy. So definitely it is a higher level of support because it gives you PEEP. So it can help you improve your oxygenation. So both these therapies are comparable. Non-invasive ventilation where we use the mask, and also high flow nasal cannula. Now, where you can use it during tracheal intubation is very, very important. You can use it during pre-oxygenation. So your patient is already on this high flow nasal cannula oxygen, and now you are going to intubate. Maybe he's deteriorated, so now you have to intubate. So when you are doing laryngoscopy and putting tube also, you can keep this high flow nasal cannula oxygen during attempts at intubation. And this gives another very good therapy, and that is what we call today apneic oxygenation. That means even when the patient has been given muscle relaxant paralysis for tracheal intubation, still you can continue oxygenation passively during apnea. And this is what your high flow nasal cannula oxygen can help you, because the cannula is in the nostril and you are doing laryngoscopy through the mouth. So oxygenation continues, and this can prevent desaturation during attempts at intubation, and it can prolong the safe apnea time period, from 8 minutes up to 45 minutes to 1 hour. Patient will not desaturate. So very, very useful therapy. The other area where you can use it is patient is on a ventilator for many days. Now you're going to extubate him, and he's a high risk patient. You are very worried that again he will deteriorate, again he will get reintubated. So such patients, you can take out the tube and you can put them on high flow nasal cannula oxygen. So instead of putting them on plain oxygen mask, you can use this therapy. So this can be used in high risk patient. So in the pre-COVID era, this is the evidence for the use of high flow nasal cannula oxygen. Right, so I just want to give you an idea that what was the evidence level for using this therapy and where were we using. Now what was the problem in COVID? Now everything changed with COVID. So all along we were thinking that, oh, high flow is very good therapy, we must use it in patients who come with acute hypoxemic respiratory failure. But COVID created a new problem. COVID created the problem that you are using very high flow, and initially, we were thinking of it as a droplet infection. But later, there was concern that this produces aerosol. And if you are using such high flow, there will be aerosol generation. And if there is aerosol generation, then of course, there is risk to the healthcare worker. So the first time we were not only thinking about patient benefit, which we already know is there with this therapy, but we were also thinking about safety of healthcare workers. So actually, unfortunately, in the beginning of the pandemic, HFNO therapy was not used at all, because they said no, this is an aerosol generating procedure, so we will not use HFNO because there is risk to the healthcare worker. So what was happening in the first few months of the pandemic, especially in India, is we were giving oxygen therapy, और अगर patient deteriorate हो जाता था तो वो intubate हो जाता था. So we were intubating very early. We were putting patients very early on mechanical ventilation, and because of that, there was also a lot of morbidity and mortality. But over time, we learned that this risk is much less than what we thought. And we started using this therapy more and more. And we realized that what will really protect you or the healthcare worker is the personal protective equipment, which we should do wear appropriately. So I just like to tell you that initially there were some studies because people were very concerned कि सच्ची में इतना aerosol generation होता है क्या therapy से. So this is the kind of studies that what they did is they looked at exhaled smoke. Now this was done in mannequins, of course they could not do this kind of study in patients. So they used exhaled smoke and they used laser light. And this was a very interesting study published in the European Respiratory Journal. And what they did is they made three different types of lungs: normal lungs, and this is of course in mannequins. Normal lungs, they used patients with moderate disease and severe disease, and then they gave them different flows, 10 liters, 30 liters, 60 liters to all this mild, moderate, severe lungs, artificially created lungs. And then they used this exhaled smoke and they looked at what was the dispersion in distance of this smoke. And of course, it was highest in patients with normal lungs. But what they saw is that in mild and moderate, mild and severe damaged lungs, the dispersion was not so. So it was not so much a concern as was imagined. And this is a more recent study that was published in 2021 in American Journal of Respiratory and Critical Care Medicine. And here they did a very interesting thing. What they did is they kept different plates and they used bacteriophages. Again, this was done on mannequin simulation model that they created, and at different levels, right in the oral, near the oral cavity where the intubation is being done. वहाँ पे एक plate रखी patient, then near the patient's head, then also the assistants during tracheal intubation, wherever they stand, there they kept plates. They also kept at the foot end of the bed. So different position they kept plates, and then this mannequin exhaled bacteriophages, and then there were plates, and then they would do the look at what was the viral dispersion associated with different respiratory devices. So what they used was regular oxygen face mask, non-invasive ventilation mask, then yeah, high flow nasal oxygen therapy, then intubation, and they also there is like another non-invasive device is there, and that is called the helmet. So this is not available much in India. It's like a full helmet around the head. So they also looked at this device, and they looked, and what was the results that they found? So they found that in different the plates were at different places, and here you can see what is in blue is tracheal intubation, and what is in red is helmet, which we don't have. The full thing covers. It's a non-invasive device. It's like a helmet. So patient is more comfortable, and from an infection standpoint also, the aerosol spread is minimal. So here what they found is with tracheal intubation and with helmet, the viral dispersion was the least. But in terms of patient wearing nasal prongs, or patient with the non-rebreather regular mask, or with the NIV or high flow nasal cannula oxygen, you can see at all the different places around the bed, it was much higher than intubated patient or with helmet CPAP. However, among them, it wasn't significantly different. But we know today that there is aerosol generation. But what we have realized is that what really protects you is your personal protective equipment. So concerns are there. There is aerosol generation. However, not to such an alarming rate and not so different from the regular face mask or the nasal prongs that we use. So what was happening early in the pandemic is we hardly used this because there was this hypothetical risk of transmission of infection to the healthcare workers. And expert opinion recommended that don't use it, or if you use it, so flow come use karna, only 30 liters for critically ill patients. And because of this, what happened is the ICU doctors were restricted. So if they didn't use it, only face mask, oxygen, patient deteriorated, then they would intubate and put on a ventilator or not intubate at all. So this is what was happening early intubation. But over time, this risk of bioaerosol dispersion with HFNO, ever since that time, has been questioned. कि सही में इतना aerosol generation होता है, इससे इतना risk है healthcare worker को. And this was a WHO commissioned review. So they said, look, we have to use this therapy. It has been beneficial in non-COVID. So let us do a quick meta-analysis of all the studies that have been published. Very few studies, many came from China, retrospective data. They said we want to evaluate, one is efficacy in COVID patients, and secondly is what is the safety of the device. So this in brief, I will just tell you that the study that they did showed that when HFNO was applied to patients with respiratory failure, it substantially reduced the need for invasive mechanical ventilation, okay, and therapy or to NIV or intubation in patients without increasing mortality. So we knew that there is a benefit like in non-COVID patients. And they said there's very low certainty of evidence because the studies were very few that regarding to the droplet dispersion and aerosol generation. So until evidence evolved, what we learned was that what is most important is aerosol generation hoti hai nahi hoti hai pata nahi. Let us use appropriate PPE and protect yourself. So if you wear your N95 mask, you wear your PPE appropriately, let us give the best therapy that we know is beneficial to the patient, and at the same time we stay properly protected. So towards the second half of the second wave, first wave, we started using across India in ICUs, in ward, we started using HFNO, and this avoided a lot of tracheal intubations, avoided a lot of mechanical ventilation, and we were able to decrease the mortality compared to early in the pandemic days. Now, if you look at high flow nasal cannula, let me just show you some of the studies, just in brief, to give you an idea, because whatever data we had until now was in non COVID patients. Now, let us see what is the data that we have in COVID patients. So, in COVID patients, have there been a study? So, this was, of course, a retrospective study. What they did is they looked at all the patients retrospectively, consecutive patients, those who received standard oxygen therapy or they received high flow nasal cannula oxygen, and they looked at how many patients got intubated and mechanical ventilation. And as you can see, the p value is less than 0.05, so it is significant. So there was a significant benefit of using HFNO as compared to standard oxygen therapy to avoid mechanical ventilation in patients with SARS-CoV-2. So we know there is a benefit, but this was a retrospective study. Okay, so HFNO in COVID-19 patients with acute respiratory failure was associated with lower risk of invasive mechanical ventilation. Then this is another study, more patients, almost 400 patients, again retrospective study, and they did some propensity matching. And here they found when you use HFNO versus not using HFNO, they saw that invasive mechanical ventilation is much lower, and more patients got discharged from ICU, but there was no difference in the mortality between the patients. But definitely benefit of not getting ventilated and going home out of ICU more patients if HFNO was used. So definitely benefit of therapy in COVID-19 patients. The two studies that I showed you were retrospective studies. This was the first prospective study that was done. And here again, they took consecutive patients with COVID 19, and they took a cohort of equal number of patients with on which who were given oxygen therapy and who were given HFNO. And then they looked at, and this was propensity matched. So they were matched for severity of illness. And what they found is if you look at patients who get HFNO, this is the pink one, if you looked at the ventilator free days or the ICU length of stay or even the mortality, it was much lower in patients who got high flow nasal cannula oxygen as compared to patient who got conventional. So this is all data that we have in COVID-19 patients, and so definitely showing lower mortality, lesser ICU stay, and lesser more days free of ventilation when you use HFNO in patients with COVID-19. Now, this is very interesting. This was a study that was done where they used surgical mask on top of high flow nasal cannula oxygen. And this is something very practical and very useful. Now, why would you put a surgical mask on top of high flow? Of course, from an infection standpoint, it can serve as a barrier and protect the healthcare worker. But not only that, this improves oxygenation. Okay, so this was a simple study in which they use high flow nasal cannula oxygen and they put a surgical mask on top of that. In one group, they put the surgical mask. In one group, they did not put the surgical mask. And a very interesting findings. Now, what you see in white is HFNO with surgical mask on top of the patient's face. And what you see in black is without the surgical mask. And if you look at the oxygen saturation, if you look at the PaO2 or the PaO2 FiO2 ratio, everything was higher when the patient got, when had the mask over the face. And they also looked at patient comfort because sometimes you're using already HFNO, उसके ऊपर से mask डाल रहे हो. So they did survey on patient comfort, and there was no difference in the patient comfort with or without the mask. They also looked at CO2 rise, whether there was any difference. People are always worried, अरे mask पहनो, CO2 बढ़ जाएगा. There's always people telling you all this. But with the surgical mask, there was no increase in the difference in the PaCO2 between the two arms. Well, now this was very interesting result because I thought, okay, infection protection, theek hai, but how does this improve oxygenation? So one of the theories may be that you wear the mask over the high flow nasal cannula oxygen, and patient tends to keep the mouth closed. As I told you, if you keep the mouth closed, the PEEP effect is not lost, and you can improve the oxygenation by giving PEEP to the patient. And second is the concentration of the oxygen. So these are the two plausible theories, but we can never say with certainty. But definitely, this is very good from an infection standpoint, and it is also good to improve the oxygenation. And this is the recommendations that were published in Critical Care Journal. So you can see this is the nasal cannula and simple face mask that you can be putting. Okay. And what are the recommendations that are given with the nasal cannula? Can you mute your mics, please? Because I'm hearing a lot of cross talking. Can you please mute your mics? Thank you. Yeah, so with the use of high flow nasal therapy, there are two recommendations to optimize the use. One is the cannula should be tight fitting. Now, this is very good even if you don't want oxygen wastage. So you must use cannula of the right. It should be properly fitted cannula. Half the time, what happens, the nasal prongs are not inside the nostril, they're outside or not properly fitted. So make sure they're properly fitted. This is good from an infection standpoint and also oxygen conservation standpoint. And you can use a simple face mask. This will also be good from an infection standpoint and also improve the patient oxygenation. So this is a simple practical solution. When you're using high flow, remember to put a simple surgical mask over the patient's face. Now, whatever studies I showed you, those were studies that were either retrospective or very small in numbers. And the real benefit and when to use and when to decide to stop high flow and intubate the patient, how long you could use it, in which clinical setting you would use it, there was no data or guidance regarding this. So along with a few other Indian investigators, we led a Delphi process among international experts in respiratory failure to gather consensus on this topic. So what we did is we took 39 international experts from different parts of the world, and we said, Chalo, we will do a Delphi process, proper scientific systematic process to generate consensus about HFNO. And NIV also was done just to do this. So I was very proud to lead this study. And we published this, I was last one corresponding author. We published this in the journal Critical Care. And this was done with 39 international experts from 20 countries and 6 continents. So this is really the first guidance from international experts on the use of non-invasive respiratory support in COVID-19 patients. So this is just about the process. I don't want to bore you with this, but we had multiple choice question, Likert scale questions, and we had a blinded process. We had 6 rounds in our Delphi process, and then we tried to gain consensus among all the experts. And we also looked for stability, and based on this, we made recommendations from these 39 international experts. And I will just tell you how we did this. We had 73% consensus, and from this, we made 20 clinical practice statements on the management of acute respiratory failure. Different aspects. Awake proning karna chahiye ki nahi, high flow, whether to use prone ventilation, steroids, different aspects of acute respiratory failure. But I will only tell you about what was the consensus among international experts related to HFNO. So what they said was HFNO therapy should be considered as an alternative oxygen support strategy. So definitely when your patient comes in acute hypoxemic respiratory failure, you should consider giving HFNO to this patient. Now, who should you use it in? This should be used in patients. Now, you use oxygen mask, right? Patient will come straight away. You don't use HFNO therapy. You use oxygen mask. Now, if you see the patient is not able to maintain saturation over 90% with the use of your regular Venturi mask, yeah, or you see that the oxygen requirement is rapidly increasing, such a patient, you should use high flow nasal cannula oxygen before they get intubated to avoid mechanical intubation. So, the other consensus was that this will avoid the need for tracheal intubation and invasive mechanical ventilation. What you see in bracket is how much was the consensus among the experts. So these were the 3 statements that you gave, and definitely, like in non-COVID patients, they established that there is a benefit of giving in COVID patients, and in which setting you should give this, and what can it do? It can avoid invasive mechanical ventilation. And like I told you, if you're on the maximum setting, maximum FiO2, and flow is already 60 liters, and still patient is breathing at the rate of say 40, patient has nasal flaring, clinical signs of respiratory failure. In COVID, one very important lesson we have learned is go purely clinically. We have seen that CT scan and respiratory failure and patient's clinical setting, presentation has no correlation. No CT score, there's no correlation between what you see in the CT scan and how the patient presents. You see the patient very comfortable. You see the CT scan, you will think I should intubate him just now. You see the blood gas, you know that these patients are happy hypoxics, they can tolerate this hypoxia. So in COVID, what we have learned is not repeated CTs, not repeated, various levels of various inflammatory markers. What we need to see is look at the patient clinically. If the patient is comfortable, if there are no signs of respiratory distress, if there is no increased work of breathing, the simple bedside clinical signs, even a ward boy or a technician looking at the patient will say, "अरे ये तो अच्छे से सांस नहीं ले रहा है, ये तो थक गया है, इसको तो intubation लगेगी." You can easily clinically look at the patient and you can say whether he is comfortable on the therapy or not. So if you see this happening at the maximum level of support, then you need to intubate the patient. Then you must not wait. So it is not about early intubation or late intubation. There was big debate. Should we intubate early? Should we intubate late? I will say it is about intubating at the right time. When you see clinical signs of respiratory distress and patient is not able to maintain saturation above 90%, this is your cue to intubate the patient, and you should intubate at the right time. At this point, you should intubate and not wait till he gets completely exhausted and decompensate, because mortality has been very high in patients who are on high flow nasal cannula oxygen in whom intubation was delayed. So this is the level of monitoring that is required on a patient in high flow nasal cannula oxygen. So I'd like to conclude by saying that HFNO therapy should be considered as an alternate oxygen strategy for oxygen support in COVID-19 patients. This is definitely a therapy we should use. Very, very simple. It has saved a lot of lives, and it will save a lot of lives, not only in COVID, but even in non-COVID patients who present with acute hypoxemic respiratory failure. Very important. The concern of transmission of infection to the healthcare worker should not limit either the use of HFNO or the flow that we are using. So don't say, okay, मैं 30 flow use करूंगा लेकिन उसके ऊपर नहीं जाऊंगा. Use what is the correct requirement for that patient and protect yourself with adequate measures. Now, we know today that HFNO reduces the need for invasive mechanical ventilation. It can increase the ventilator free days. It can reduce the ICU length of stay. And there is no apparent effect of on mortality. So, future studies need to confirm these findings. But we already have data internationally on COVID-19 patients. And we also have consensus from global experts in respiratory failure about the indications for use of this therapy and in which situations you should use this therapy and for how long we should use this therapy. So strategies to reduce transmission of infection. Of course, we are worried in COVID-19. We want to give our patients the best, but we have to also protect the healthcare workers. So we have to be, conscious about transmission of infection to the healthcare worker. So for that, you should use appropriate PPE, and the best thing that can protect you is the N95 mask. We know today that the fomites are not so much of a concern as we were worried. We may not wear a full PPE and gown and gloves and everything. You can wear a little modified, but N95 mask definitely, because we are not 100% sure today whether this is aerosol generating or not. So until such time, I would say definitely wear an N95 mask when you are with a patient of COVID-19, especially when you're using HFNO, because this is aerosol generating procedure. And most importantly, the nasal cannula should be properly fitted. Pay attention to this. When you look at patients on HFNO therapy, very often the cannula is not well fitted or the cannula is not in the nostril. So this can save oxygen and also avoid, transmission of infection to the healthcare worker. And you can wear, as I showed you, a surgical mask should be put over HFNO. This will not only help in preventing the transmission of infection, but may also help improve the oxygenation. I'll end by saying that wherever you are listening to me, please do take care and stay safe. Thank you very much for your attention. I'm happy to take questions.
It was a very nice and elaborate presentation on use of HFNO, especially in COVID patients. We covered beyond COVID as well. There is one question from Dr. Ravi, who has
Yes.
put forward. How do you read whether you use a flow fast or you reduce the file? If you can elaborate on that.
Sorry, sir, I did not hear. I cannot hear
How
that.
do we wean from HFNO, whether we look target flow fast or we target the file?
Yes. Okay. So this is a very, very good question. I'm sorry I didn't mention it during my presentation. So you look at the patient, you have a particular setting. Like I said, you will set the temperature around 34, 35. And the other two settings are the flow and the FiO2. So now as your patient gets better, you need to titrate this. And unlike invasive mechanical ventilation, where the PEEP and FiO2 move in parallel, you cannot give 80 FiO2 and give very low PEEP, right? So they move in parallel. We have a way of titrating the PEEP FiO2. In this, the FiO2 and the flow, there is a complete disconnect. So I must decide now what is my target saturation for this patient. So if I say my target saturation, I should keep saturation above 90. So you go on reducing the FiO2 to match the requirement. So supposing my patient is maintaining 98% saturation and I am on 60 FiO2. So I will reduce to 50. Again, if he is maintaining 98, I will come down to 40. I will come down further till I have reached that FiO2 which is able to maintain the saturation above 90. Definitely, you don't come from ekdam 100 to 21%. You have to do this gradually because otherwise your patient might just rapidly desaturate. So this is how you de-escalate the FiO2. Always remember when a patient comes very tachypneic, very breathless, give maximum oxygen 100% first. Even if it is not required, give 100% and then gradually come down. Then you look at the worker breathing. Now this device can give you 60 liters of flow. 60 liters of flow of oxygen per minute. So as you see, as I mentioned, you don't need to keep at 60. When the patient comes after 1 or 2 hours of the therapy, you will see patient is very, very comfortable. Then you start coming down. So you come down to 40 liters, come down to 30 liters. So remember, high flow is therapy 30 liters and above. There is no point coming below 30 liters. Okay, because it has to be higher than the peak inspiratory flow rate. That is how the therapy works. So keeping at 10 and 15 and all this is useless. So the flow has to be 30 liters and above. And you go on coming down, and it is so simple to do at the bedside, because you just look at the patient. You don't have to look at any ABG, any X-ray chest, any CT scan. You look at the patient. When the patient is on 50 flow, you are seeing he's comfortable, he's breathing at the rate of 20-25, saturation is maintaining at 94. Patient is not, there's no air hunger, there's no nasal flaring, there is no indrawing of the intercostal muscles. You can see patient is very comfortable. Then I have the confidence to reduce the flow further. So you can go down up to a flow of 30, and FiO2 you can keep on room at 21% also you can keep. And as I show you, there is air entrainment. Depending upon what FiO2 you set, there is a blender in this machine. And this blender mixes the air and oxygen to give you the desired FiO2. तो अगर आप कम रखोगे, FiO2 कम रखोगे, तो ज़्यादा air entrain होगा और कम oxygen deliver होगी. So this is the way that it works. So the point I want to make is, don't say 100 FiO2 60 flow, then 90 FiO2 55 flow. ऐसी नहीं होती. You have to titrate depending upon needs. FiO2 based on saturation target, and flow based on patient comfort, respiratory distress, and work of breathing. I hope I was able to clarify that.
One more question.
Yes, sir.
How different are standalone HFNO device compared to the ventilators which now have integrated HFNO? We are now getting the ventilators which have got integrated HFNO.
Sorry, sir, आपकी आवाज नहीं आ रही. Standalone HFNO devices.
Device and new ventilators which have got HFNO algorithm incorporated.
Ventilators which HFNO incorporated. Is that your question, sir?
Yeah, that is.
Yeah, so these standalone devices, these come from Fisher and Paykel. These standalone devices are there. We also have ventilators which can give high flow. So if you have that, that is also very good, because you can use high flow therapy, and then when the patient gets intubated, you can use the same ventilator to continue the invasive mechanical ventilation. But I can tell you one thing, especially with more of a general practitioner audience here, I think these devices have really revolutionized the kind of respiratory support we can give patient with minimal monitoring and minimal, expertise. And it is a perfect bridge between just simple face mask and invasive mechanical ventilation. So if this face mask oxygen failed, it was just intubate the patient, right? Or people were not intubating at all. They were saying, okay, just leave the patient. So this gives you a level of comfort. And I can say, at least in Mumbai, in OPDs, in nursing homes, in ward areas, these were set up by technicians were setting them up, and families were monitoring the patient and seeing that, they were okay. So it's very, very simple to use. You just need to be able to adjust these settings. So this is not like patient on ventilator where you need an expert who understands invasive mechanical ventilation. So I can say that in an ICU, definitely it's good to have a ventilator with HFNO incorporated, but it's important to have these standalone devices in areas, especially outside the ICU. We have a lot of HFNO machines in the ward which are being used, and they can avoid ICU admission by using the HFNO in the ward. So both devices have its place.
A nice elaborate discussion from your side. It was a pleasure to have you as a celebrity speaker. Very nice talk. I think it's time we close the session, and thank you. We look forward to having you again. And,
Thank you very much.
thank you.
Thank you very much.
On behalf of team IMA CGP, I would also like to express my thanks to Professor Sridhar. It was nice to hear from you, and especially on an important and a difficult topic of HFNO. So I think we end this session, and thank you.
Thank you very much.
Thank you, Dr. Sanjay, and the chairpersons of this session. So we can now move forward to the next session, which is on guiding alarms. So for this, the speaker is Professor Renu Mishra. And conduct this session with the stakeholders. So welcome, Dr. Usha.
Welcome to the dynamic session of 38th IMA CGP leadership course. आज हम लोग का टॉपिक है drugs in pregnancy policy. Pregnancy and postpartum period almost एक साल का पीरियड होता है जिसमें कि लेडी प्री एक्सिस्टिंग कंडीशन में एंटर कर सकती है जैसे एपिलेप्सी, माइग्रेन, ब्लड प्रेशर, डायबिटीज और ऐसा ड्यूरिंग प्रेगनेंसी भी कुछ कैरी कर सकती है जो नॉर्मल प्रेगनेंसी कंडीशंस होती है जैसे मॉर्निंग है आपका वेट गेन और मेडिकल डिसऑर्डर्स प्रेगनेंसी हो सकते हैं डायबिटीज, ब्लड प्रेशर, हाइपरटेंशन, डायबिटीज और infections like urine infection, upper respiratory infections, perit infections. तो बहुत dilemma होता है कि क्या दवाई दी जाए क्या नहीं दी जाए क्योंकि जो भी दवा दी जाएगी that can be safe for the mother or and fetus or it may be unsafe for the mother and the fetus. So we will have a talk with learned speaker Dr. Renu Mishra from AIMS on this subject. You're welcome to listen to her. Dr. Renu Mishra will be introducing Dr. Renu Mishra. It's my great privilege to introduce a great speaker from All India Institute of Medical Sciences. And at present, she's Dr. Renu Mishra. She's a senior consultant obstetrics and gynae at present, and her area of interest are endoscopic surgery, infertility, and IVF. She's a director of Kamna Infertility Center, IVF Sector, Gurgaon, and in Sitaram Bhatia Institute. Endoscopic surgery. She has got training in Rutanda Hospital, Dublin, Ireland, 2010. She has authored 5 books and she has got published 50 articles in journals, and she has given 300 guest lectures, and she is the past president of Delhi Gynecological Endoscopic Society. So over to you, madam. Thank you so much. The chairperson for this session are Dr. Meera Ginootri, Dr. Kiran Pandey, and myself. So over to you, madam. Dr. Renu.
Can I share my screen?
Yes, ma'am.
I'm disabled. Somebody will have to enable me to share my screen.
That doesn't mean
No. Am I audible?
yes, ma'am. Very well.
Till the time that I get my sharing rights. So good afternoon, everybody. Can I start sharing? Oh, yes. Yeah. So good afternoon, everybody. I welcome all of you, those who have logged in for today's webinar. At the outset, I would like to thank Dr. Neelam Mishra, President IMA Kanpur, and also like to thank the chairpersons who joined in. I wish I was there physically, since I have a special attachment to Kanpur. I did my schooling from Methodist High School, Kanpur. But anyway, virtual is better than nothing. So starting with my talk, I have taken the liberty to include, besides drugs, radiation, because the same question arises like we have with drugs, whether the X-rays are safe, whether the vaccination is safe. So I've included drugs, radiation, and vaccines during pregnancy. So we know that, so just a minute, let me just remove this from my screen. Too many things coming on my screen. Okay, I'm not getting a gallery view. Sorry. Okay. So we know that about 3 to 4% of all babies have congenital malformations, which can affect the way they look. That means physically, physical features, how they develop, their organs, or how they function mentally and physically. And these anomalies can occur due to insults which occurred in the fetal in utero time. And these could be drugs which we prescribe. These could be environmental chemicals, radiation. This could be radiation by diagnostic imaging, the X-rays, CT scans, or sometimes people are worried whether the vaccination is going to harm the in utero fetus. So if you look at the causes of congenital malformations in the babies, then chromosome anomalies are the commonest. In fact, I always tell the patients when they have an abortion, I tell them this is nature's way of cutting down on handicap. You know, if all these babies with chromosomal anomalies were born, we will have so many more abnormal babies. So if you see, in fact, chromosomal anomalies contribute to about 50% miscarriages. And in fact, some people say that if you did a chromosome analysis on all fetal products, it may be up to 80 to 90% pregnancies are lost because of chromosomal malformations. There could be single gene abnormalities, maternal conditions during pregnancy which arise in the mother, like viral infections, rubella, chickenpox, medical conditions, diabetes, lupus. Alcohol, of course, is a iatrogenic problem and increasing in today's society, and the drugs and chemicals that we prescribe to the patients. Environmental factors, like I said, there is radiation in the environment also. And many times we are not able to actually find out what is the cause of malformation. And a lot of these go because of unknown reasons. So coming to drugs in pregnancy. Sorry, I still want to, I'm not able to get this. Okay. Not able to get off my screen. You know, there's a lot of gallery view on my screen and I can't see most of half my slide. Anyway, so coming to drugs in pregnancy. So let us look at some historical disasters in medicine due to drug-induced teratogenesis. Thalidomide was a drug which was used very innocently in 1950s and 60s for nausea in pregnancy. And people then realized, because it produced severe birth defects in thousands of babies, and they realized that this was a very potent teratogen. In fact, babies had very severe limb reduction defects. Another disaster was diethylstilbestrol. This is a synthetic form of estrogen which was prescribed to prevent miscarriages and premature labor. And almost after 30 years of its prescription, people realized that there was a link between this exposure in utero, DS exposure in utero, and a certain type of cancer in cervix and vagina called clear cell adenocarcinoma. So that is why I always say that in pregnancy, particularly in the first trimester of pregnancy, we should not jump to prescribing medication. And I really, say this, that nowadays the medication that is prescribed, we're too keen or too eager to prescribe some medication just to satisfy the patient. Patient को जरा से 2 drop bleeding हुई तो उसको progesterone start कर दिए. She says, I'm having little pain in the lower abdomen. Can everybody please mute their audio? She has little bit pain in the abdomen. We give her progesterones, we give her estrogen. We prescribe so much hormones even in the ART pregnancies, which is not required. And who knows, after 20 years or 30 years, what are we going to find, what link we are going to get? Maybe not as gross as thalidomide disaster, but maybe we might be doing some harm in trying to do good to these patients. So we should be very, very clear whether the patient needs any medication. Otherwise, our job is to just give her tender, loving care and address her medical issues. So the question is, should we prescribe medication at all in pregnancy if we look at the thalidomide and DS disasters? Well, ideally, yes, if we could avoid all pregnancy, all drugs in pregnancy. But this is not an ideal world. If you had women getting pregnant between 20 and 25, fit young women without any medical disorder, maybe they won't need any medication. But with women now planning pregnancies later in life, after 30, after 35, very ambitious, even medically we are ambitious. Women are conceiving after heart transplant, kidney transplant. How is it possible that she can continue or carry this pregnancy through without a problem if we stop all her medication? So it is not practical in today's world that we can do without medication in pregnancy. So medicines need to be prescribed in the interest of maternal health. If a patient is asthmatic and she cannot breathe well, obviously she's not going to oxygenate her baby as well. So babies cannot be healthy if the mother is unwell. We have to understand that. And that is the other good thing is that very few drugs are proven teratogens, which I mean to say that if you have given like 1 or 2 doses also, you're worried that you have given. Most drugs, even which are relatively unsafe, if you've just taken 1 tablet, it will not usually harm your baby. So that is a good thing. And of course, the goal of medication in pregnancy should be that we use drugs with good safety record. Other than pregnancy, non-pregnant women or men, we are nowadays very, very keen to try new medication. कोई MR आया, उसने नई दवाई बताई, डॉक्टर साहब ये ज्यादा अच्छी है, इसकी बायोअवेलेबिलिटी ज्यादा अच्छी है, ये स्विट्जरलैंड में मॉलिक्यूल बना है, ये तो बहुत बढ़िया है, इसके साइड इफेक्ट्स नहीं है, you must try this. They will show you 3 publications which they have, sort of got done with some local doctor, and they will show that this is a very safe drug. Well, not that is a very good prescribing way, but still if it is in a non-pregnant person, you probably wouldn't harm much, and at least there is no issue of safety to the fetus. So when it comes to pregnancy, sometimes we use drugs which are not that good, like we've been using methyl dopa. Now, of course, we've moved over to labetalol, but we used methyl dopa for years and years and years when we knew this was not such a good antihypertensive. The only reason we were prescribing was because it was safe. It was there for 30, 40 years and it was safe, so we were giving it. And the other thing, if patient has a chronic medical condition and she is on some medication, either before the best would be she comes for pre-pregnancy counseling. Otherwise, as soon as she comes to you when she's pregnant, we need to see whether this is the best drug for her in pregnancy from fetal point of view and what is the optimum dose of pregnancy. So keep them on the safest and the lowest dose that is required during pregnancy. We also need to understand the effect of drugs and on fetal age. The problems that can occur in the fetus also depend on which part of pregnancy or which gestational age you are giving that drug. So if the drug is given before 20 days after fertilization, when I say 20 days after fertilization, that means from LMP, you have subtracted 2 weeks, because you presume that fertilization would occur around the time of ovulation. And in a regular 28-day cycle, you will have ovulation somewhere around day 14. So up to 20 days after fertilization would be 5 weeks from LMP, because that's easier to understand for us. We all look at the LMPs. There is all or none effect. So either the pregnancy, if it is affected, the baby will not grow at all and the pregnancy will miscarry. But if it does continue, it does not cause any birth defect. So the teratogenesis is very, very unlikely at this stage because the pregnancy is very small. It has not differentiated into different organs. The peak period of teratogenesis is the peak period of organogenesis. That is 3 to 10 weeks from LMP. And this is the time where maximum risk occurs to the fetus due to drugs or other environmental problems. After organogenesis, that is in the 2nd and 3rd trimester, teratogenesis doesn't occur. That means you will not have a major birth defect, but you can affect the baby's growth and the function of different organs by drugs or other chemicals. It's probably easier to understand looking at the diagram. So if you see, this is the 0 to 3 weeks. This is from LMP. That is where you will not have any teratogenesis. The pregnancy will either continue or it will miscarry. And between 3 to 8 weeks is the time where you have the maximum risk of teratogenesis. So how do we look at safety of drugs in pregnancy? Till now, FDA had given categories A, B, C, D, and we've really grown up with them. And we knew that if the drug was category A and B, then it is safe in pregnancy. C, you could give it if you really think that this is necessary, or otherwise avoid it. D was a complete no-no. So this is what we have grown up with. But FDA has now withdrawn these categories A, B, C, D. The reason why they were withdrawn, FDA said that this is too simplistic an approach to think that a medicine could be A and B for the entire pregnancy. And there are medicines which would be harmful if they exceed a particular dose. So whenever you prescribe any medicine, you have to look up for that particular medicine and check what is the harmful effect, in whether it is seen in humans, whether it is seen in animal data. So we need to check for every drug. We cannot just say that even you cannot take a group of drugs and say that, okay, all these drugs are safe. So we need to check for every drug before prescribing. And the new categories that they have given is compatible. Compatible means there is human data which shows either no harmful effect or negligible risk to the fetus. Probably compatible where human data may or may not be available, but you don't think looking at the drug characteristic that is likely to harm the fetus. Like if you have a drug which does not cross the placenta like insulin, so it is unlikely to cause teratogenesis because it is not going to the fetus. And of course, these categories also may change. A drug which is probably compatible today, as soon as we generate some data in humans and we have a long safety record, it may actually move to the compatible group. So again, you have to check out on every drug. Then there could be some drugs which are compatible. Maternal benefit exceeds fetal risk. And so they may be given in maternal interest. Then human data may suggest low risk. These are again comparatively safer drugs because there is low risk by human data. There could be no or very limited human data, and animal data may suggest risk factors, either low risk or moderate or high risk. So they again have to be looked into, and you have to read up what is the animal data suggesting, what kind of malformation it can create. And then there are drugs which are clearly contraindicated. Some are contraindicated only in the first trimester, and some are contraindicated only in the second and third trimesters. That is also important to understand. So how do we cope up with this? I mean, it sounds very difficult that we need to know about each drug. I can suggest a simple way. Like everybody has internet now, but you don't have to look up every drug when the patient is sitting in front of you. We can have a list of common drugs that we prescribe day in and day out. Some odd drug you can look up and always tell the patient that I will tell you later. But common drugs that you prescribe every day. So you could actually have a small sort of sheet print out either in your office, put it in your office, or you could have it on your mobile. Like we have so many things on the mobile nowadays. The latest, edition of my textbook, which I wrote, Ian Donald Practical Obstetric Problems. Sorry, can I just take his phone? Dr. Neelam is calling me. Hello? But मेरा तो connection तो मैंने फोन से कनेक्ट कर लिया. हेलो, am I audible now? Can anybody respond? Hello.
Yes, ma'am, you are audible.
Okay, because I've connected from my phone. Dr. Neelam was saying that my voice is breaking. Okay.
Yeah, you're audible.
Yeah, so I'm going to share my screen again. Sorry for this. गुड़गांव में भी बिजली बहुत जाती है. So actually disconnected because of that. Okay, so okay. So what I was telling you, that you could always, print out, have a small sheet of paper in your office with common drugs that you prescribe day in and out, or have it on your mobile. Or like I was saying that the latest edition of my book, Iron Donald, I've actually given an extensive chart at the end of the book, which gives you all the common drugs and gives you the potential problems or harm that it can cause during pregnancy and lactation. So you need to have these sort of ready reference with you nowadays before you can prescribe. So this I have told you. Okay, so common prescription drugs, I'm going to share with you the, somebody is raising a hand. I really don't know. I mean, please, you can speak out if there's something. So some common prescription drugs that I will show you. Coming to drugs we use for nausea and vomiting in pregnancy. So cyclazine, doxycycline, meclizine, metoclopramide, these are compatible. That means these are safe and can be used without restriction. Actually, I have made these, put in these colors. Green is completely safe. Yellowish orange is little unsafe. And the pink or red will be unsafe. So this is just for you people to, easily sort of grasp which is safer. So these are compatible drugs. Ondansetron, when I was reading up, I was surprised myself. Even I use ondansetron in the first trimester, but it says that there is increased risk of cardiac anomalies. So I am going to stop using ondansetron. Having said that, like I said before, if you have given 1 or 2 tablets at any time in pregnancy, even if a drug comes into a relatively unsafe zone, it usually will not do any harm to the baby. So one should not be overly scared also of giving a tablet. And unless the medicine is taken in bigger doses and continuously first time, usually they are not harmful to the baby. When we look at the painkillers, paracetamol is compatible. These are all the NSAIDs, and they all have a similar safety level. It says first trimester spontaneous abortion and congenital malformations, there is a risk, but the absolute risk is low, which means again that if you have taken 1 tablet of Brufen or 1 tablet of diclofenac, you're not going to have a birth defect. So one doesn't need to get so scared or scare the patient that you've taken 2 tablets of ibuprofen and this will cause some problem with the baby. But preferably if we could use more paracetamol, which is safer than NSAIDs in pregnancy. So antibiotics, again, we need to prescribe many times during pregnancy because pregnancy is a 9-month span, and to expect that no problem will happen, nothing will go wrong, patients will not have any infections. Of course, many times you are lucky and you don't have a problem, but then it is not unusual to have a situation where you need to prescribe antibiotics. So these are all safe, azithromycin, cephalosporin, clindamycin, clarithromycin. These are all safe. Amoxicillin, ampicillin, amoxicillin clavulinate, which is we all know as Augmentin. There is some incidence of increased oral clefts in the first trimester. And if you give it to preterm babies, then there is a risk of necrotizing enterocolitis. So this should be avoided in preterm babies or near-term babies. We should be giving other antibiotics. Fluoroquinolones come in the relatively safe group. So if you think that, suppose a patient has a UTI, which is not sensitive to other things and you have to give it for some time, maybe you give it. But again, if you have another option, which is in the green, or which is more safe, you could actually switch on to other antibiotics. Nitrofurantoin, again, I have given it a lot in the first trimester, and it is not teratogenic. So you can give it in first trimester. The only reason it is in the sort of yellow range is that human data suggests that in third trimester, it can cause hemolytic anemias in newborns, which is again not a common problem, but we should be aware that this can happen. So it is probably avoided near term in third trimester, but earlier it is very safe. And nitrofurantoin is one drug which rarely is resistant when you see a urine culture sensitivity report. So aminoglycosides, we know ototoxicity problem. Tetracycline, doxycycline, actually they are contraindicated in second and third trimester, not in the first, but we tend to not give them in pregnancy anyway. Antihypertensives, like I was talking about methyl dopa earlier, We gave it for very, very long time, not because it was a great drug, but it was very safe. It has a good safety record. Now we are using labetalol as first line drug in hypertension in pregnancy. Nifedipine is also safe. Amlodipine, it says limited human data, animal data suggests low risk, but this is also comparatively safe. We have used it for a very long time now. Atenolol, like beta blockers, there is a risk of fetal growth restriction in second and third trimester. So, and ACE inhibitors, although they are not contraindicated in first trimester again, but generally we avoid them throughout pregnancy because there is a risk of fetal hypocalvaria and renal defects, oligohydramnios. Antacids, anti-secretories, so omeprazole, pantoprazole, esomeprazole, they're all fine. Rabeprazole has slightly suggests low risk, so one can avoid because there are so many other medications that we have, so we don't need to give rabeprazole. Laxatives are safe, the ones which we prescribe commonly, bisphosphonate, lactulose. Anti-tuberculars, ethambutol, isoniazid, rifampicin are safe, and pyrazinamide and para-aminosalicylic acid, if they need to be given, they fall into the category of compatible where maternal benefit outweighs embryo fetal risk. So if they are required for maternal benefit, then they should be given and not withheld. And same is for pass. Antimalarials, mefloquine is compatible, completely safe, but other drugs, chloroquine, proguanil, pyrazinamide, artesunate can again be given if they're required for the mother. Please do not withhold because the maternal benefit generally outweighs embryo or fetal risk. And like I said, if the mother is well, that's a very basic thing, that mother has to be well for the baby to be well. Primaquine is contraindicated. Then antithyroid, just use this. So antithyroid, methimazole and propylthiouracil, they both have their problems. Earlier, we used to say propylthiouracil is very safe because there is no risk of teratogenesis, but then there were cases reported with severe liver injury to the mother. So nowadays, what we do, we give propylthiouracil, PTU in the first trimester, and many times change over to methimazole later on, because this is methimazole can cause embryopathy in first trimester. So you can actually have a mix of both drugs in pregnancy. Carbamazole has been withdrawn. Antifungals, they're generally safe, what we use commonly. Anti-allergic are generally safe. Fexofenadine has slightly suggests moderate risk. So it is best avoided because we have other drugs like cetirizine and montelukast. We don't need to use fexofenadine, which comes as Elagra or other names. So that you can avoid in pregnancy. Antivirals are all okay. Cyclovir, nevirapine, and zidovudine, they can be given. Miscellaneous drugs. So bromocriptine and cabogaline, which we give for hyperprolactinemia, and we start many times before pregnancy because patient is not conceiving, and then we continue for the initial 8 to 9 weeks. Or if a patient has prolactinoma and high levels of prolactin, then we may have to continue throughout. So both of these drugs are safe. Albendazole is compatible. Parental pamoate is compatible. So these are all miscellaneous drugs. But these ones in red should be avoided. They are contraindicated. Mifepristone, misoprostol, these are contraindicated. That means if you've given misoprostol to somebody in first trimester for an abortion, then you cannot continue pregnancy. Suppose she doesn't abort, you say, okay, so leave her alone, let her continue. You cannot do that. You then need to terminate this pregnancy because of the risk of congenital malformation. So these are contraindicated. Isotretinoin is a very big no-no. It's a very potent teratogen, which actually warrants termination of pregnancy if somebody has taken for a significant time during first trimester. These the substance abuse, street drugs, cocaine, marijuana, these are again contraindicated. They can be teratogenic. Alcohol, though it is not drug, it is iatrogenic, but I thought I will mention alcohol because fetal alcohol syndrome can occur, and actually no dose of alcohol is safe in pregnancy. Although if you see, they say 1 unit is okay, but Ideally, no dose of alcohol is safe in pregnancy. It can cause fetal alcohol syndrome with craniofacial defects, mental retardation. I will just narrate a very short anecdote to you. I went to Iowa University, and one of my friends is a professor in fetal medicine there. And when we went there, there was from India, from South India, you people must have heard Ma Amrita. She, in fact, runs medical colleges, and she's very famous in the South, probably even in the North. So she was there, and everybody had gathered to meet her. It's a big hall in a 5-star hotel where everybody was gathered. There was actually a ticket, to go see her. So I also went with my friend because she was going. And there was a 17, 18-year-old boy there were bhajans going on. Ek taraf bhajan chal rahe the, and ek taraf she was sitting and, meeting people personally. And there was a 17, 18-year-old boy जो continuously dance कर रहा था. We were there for about an hour. वो 1 घंटा रुका नहीं, continuously dance करता रहा. So I just said to my friend, I said, ये बड़ा भक्त है, माँ का जो इतनी dance कर रहा है. So she said, slowly she whispered into my ear and she said, ये इसको fetal alcohol syndrome है. So he was mentally retarded. So it is not a joke when nowadays we don't take it seriously. Cigarette smoking, alcohol is on the rise in girls and women. We need to be very, very sure that in pregnancy, it is not a great idea. So coming to vaccines in pregnancy. Is it vaccines or is, yeah, okay. So vaccines in pregnancy, all these are contraindicated. Measles, mumps, rubella, varicella, yellow fever, BCG. The reason these are live attenuated vaccines, which means that the viral infectivity is attenuated. It is significantly reduced, but not zero. So to be on the safe side, these are contraindicated in pregnancy. And not just in pregnancy, if somebody takes this vaccine, we always tell them to avoid pregnancy for the next 4 weeks. And only then they should try for a pregnancy, just to make sure that there is no sort of remaining, particle of the virus in the body, and there is no risk of infection at all. But when I say that they are contraindicated and we need to counsel that they don't get pregnant for 4 weeks, there is no case of congenital rubella or varicella reported so far after a vaccine being given inadvertently during pregnancy, during first trimester. So if you by mistake have given a vaccine to somebody, or somebody has received a vaccine in the first trimester, or she gets pregnant within 4 weeks of the vaccine, it is not really advisable to do an MTP. So MTP is not required if inadvertent vaccination is done in the first trimester of pregnancy. Vaccines which can be given during pregnancy and which we give, sort of day in and out. One is tetanus. We've been giving for years and years. Nowadays, we have actually replaced the second dose of tetanus. The first dose we give tetanus, and the second dose we give at 28 weeks. We are giving Tdap, which is not just tetanus, but it is tetanus, diphtheria, and pertussis, because our pediatric friends said that till the time that the baby gets the dose of diphtheria and pertussis vaccine, the babies are not protected, and there is a risk of having these diseases in a newborn. So we are giving Tdap as a second shot instead of tetanus. Influenza vaccine can be taken, and people do take every year. And in fact, like we are giving corona vaccine, the thought is that influenza, if it occurs in pregnancy, can become more serious. So pregnant women are actually advised to take influenza vaccine, particularly if the pregnancy is happening in that period, in that season. Vaccines which can be given if the woman is in high-risk condition means, suppose you're traveling to a place where there is pneumococcal or meningococcal outbreak, then you should be vaccinated. And same is for hepatitis A and B. If there is an outbreak, then you can take a vaccine for hepatitis A and B. I think without mentioning COVID-19 vaccine, we will not be completing today's webinar on vaccination. So pregnancy, there's actually a very nice guideline produced by the MOH, Ministry of Health and Family Welfare, which is freely downloadable. You can read it on the net. And if you read it, it says pregnancy does not increase the risk of COVID-19 infection, which means that women who are pregnant are not more susceptible or not more likely to get COVID-19 infection simply because of their pregnancy. But if they do get pregnant, if they do get COVID-19 infection, the risk of severe illness and admission to ICU is more than a non-pregnant counterpart. Although, having said that, 90% women will not require hospitalization. But the ones which will, the 10%, can you please mute yourself? WHO now recommends vaccination to pregnant women. It actually recommends vaccination to pregnant women whenever the benefit of vaccines are greater than the risk to the fetus, and COVID-19 falls into that category. It is therefore advised that a pregnant woman should take COVID-19 vaccine, both doses. So we've got two vaccines now, Covaxin and Covishield. Covaxin is an inactivated virion vaccine, so there is no question of infection. Covishield uses a viral vector. It actually uses a adenovirus, which loads the viral vector, and it's sort of introduced into the body as a vaccine, and it produces an antibody or immune response, but it is not capable of causing infection. So they are both safe in pregnancy and lactation. While the mothers are breastfeeding, they are both safe. They can be taken anytime during pregnancy, even in the first trimester. There is no risk of teratogenesis. WHO does not recommend pregnancy testing prior to vaccination. So in a young woman where you think that patient may be pregnant, you don't need to find out. You can give it very safe, confidently, and counsel the patient that even if you get pregnant, there is nothing to be worried. This is completely safe because there's no risk of infection. And you do not need to delay pregnancy simply because somebody's taken a vaccine. So you say, okay, ab tum 2 mahine baad pregnancy ke liye try karna. That's not true. You do not need to test for pregnancy. You do not need to delay pregnancy, or you do not need to terminate pregnancy because somebody has been vaccinated. At the most, you can have mild side effects for 1 to 3 days, like mild fever, like you can have with any vaccine, like even for tetanus vaccine. So more than that is very, very unusual to have any major side effect. If a woman has been infected with COVID-19 infection during the current pregnancy, then vaccination should be done after the delivery. Contraindications to COVID-19 vaccine: if somebody develops an anaphylactic or allergic reaction to the first dose, then obviously you will not give the second dose. If somebody is very allergic, somebody's got a very strong allergic history to vaccines taken before or injections or drugs, then you may vaccinate them, but then they will have to be vaccinated in special sort of situation where you are all prepared to deal with if there is an allergic response, and not do it in any camp or any facility which is vaccinating others. So vaccine is temporarily contraindicated. If you have diagnosed COVID-19 infection, then defer for 12 weeks from the infection. After active COVID-19 infection, obviously there's no point vaccinating somebody. And if you have had infection and treated with monoclonal antibodies or convalescent plasma, then these women should not be vaccinated. So coming to the last part, which is the diagnostic imaging in pregnancy, but this is also a very, very important part, because although we should not be doing any unnecessary X-rays or exposing to radiation pregnant women, but many times happens that a patient, suppose she's met an accident, suppose she's having pulmonary embolism, and you need to diagnose. At that point, it works the other way. It is not in the interest. In fact, it can harm the patient if you withhold investigations which are safe. So it is good to know which investigations are safer and which are comparatively little unsafe. So it is, as medical practitioners, we need to be aware of these. So if you talk about imaging techniques in pregnancy, then we all know that imaging techniques are many times required in acute and chronic conditions, and fear of safety during pregnancy and lactation sometimes leads to unnecessary avoidance of these investigations. Ultrasound and MRI, there is no risk of ionizing radiation, so these can be done. But at the same time, we must also realize that unnecessary tests, even if ultrasound is safe or MRI is safe, we should be clear that this is required. We should not be just doing these tests for the sake of testing or saying because they are safe, you can just keep doing it. I sometimes see people doing 10 ultrasounds in a pregnancy, in a low risk normal pregnancy, which is absolutely ridiculous. So as far as MRI is concerned, gadolinium contrast should be very limited in pregnancy. This is where there's little risk to the fetus, and it should be only done when it is really indicated. So what about risk of radiation with X-rays, CT, and nuclear imaging? Now we know that ultrasound and MRI is safe, but then we sometimes do need to do some X-rays. And what do we do when we require an X-ray? So effect of gestational age also is there in radiation doses or on teratogenesis, like we talked on in drugs. So between 0 to 2 weeks after fertilization, again, there is an all and none response, just as I told you. And the estimated threshold dose, these doses are where if you exceed this dose, then there is likely to cause harm to the fetus. So this is the dose, but generally there will be no risk to the fetus, or the pregnancy will not sustain. There will be fetal demise. In the organogenesis period, as we discussed earlier, this is the highest risk of congenital anomalies. The threshold is 200 to 250 milligray. So one needs to be sure that it is, most tests in fact have much less exposure, but this is the upper limit. And during the fetal period, where I said that there could be problem with the growth of organs or the baby, the threshold doses vary. For intellectual disability, it is 60 to 3. This is a very, very variable dose. And for intellectual deficit, it is 25 IQ point. So there is a point loss per 1000 milligray after 25. So these are the upper limits. So if you generally see that less than 50 is generally safe, you can't see much except this intellectual deficit. It is saying 25. IQ will drop with 1000 milligray. So keeping these in mind, that about 50 or 25 below that, it is safe to do an X-ray. So let us see what X-rays produce or give less radiation. So these are X-rays which give very low dose radiation. You can see they're all 0.001, 0.01. So they're not even like 1 milligray. So these are safe. Of course, you don't need to do it just for the sake of doing it. But if you need to do it, please do not abstain from, like, if you have a heart patient where you want to do an X-ray, she's going into pulmonary edema, please do an X-ray. Do not avoid thinking of fetal harm, because these are completely safe. These come in low to moderate dose examination, but if you see even all these, even if you see the upper limits, none of these exceed 20 milligray. So if you require like X-ray abdomen, lumbar spine, of course, they should be done very judiciously if you need them. And but if you really need them, if you think the patient requires it, then you can go ahead. Another important area is like when you have pulmonary embolism and we need to do perfusion ventilation scan. Nowadays, we say that only perfusion scan is also enough. And these are nuclear medicine imaging, but even this is safe and should not be avoided if you are worrying about pulmonary embolism, because pulmonary embolism can be more life-threatening than the risk of doing this one X-ray or VQ scan. Even the pulmonary digital angiography, the dose is higher than the VQ scan, but it is still only 0.5 milligray. These, of course, are the examinations or X-rays, or CTs actually. CT scan gives higher radiation than plain X-rays. So if you look abdominal CT, pelvic CT, and PET CT, they are in much higher range of fetal exposure. So these, of course, we don't normally do them unless there is something very, very unusual that you require to do these tests. But 99.9%, we don't see situations where you would need to do this X-ray, because these come in the unsafe zone. So just to summarize about the imaging, so with few exceptions, radiation exposure during X-ray, CT scan, or nuclear medicine imaging is at a dose much lower than the exposure associated with fetal harm. Also, if somebody has X-rays, please do not advise to terminate pregnancy for fear of fetal harm or teratogenesis, because like I said, they are much, much lower than the threshold where you would expect fetal harm. If these techniques are necessary in addition to ultrasound or MRI, they should not be withheld in a pregnant woman. So this is my last slide. So some take-home messages, just to reiterate what I've said so far. So check for harmful fetal effects before prescribing any medicine in pregnancy. So please keep a small paper, something on your phone, something on your desk. Just stick it there so that you are sure that you're prescribing a medicine that even if nothing happens to the patient, somebody can come and question you tomorrow, because nowadays everybody is sitting on Google and internet. So make sure we need to not just protect the fetus, we need to protect ourselves also as doctors from litigation. Do not withhold medication when required for fear of fetal harm, because like I said, when mother needs it, there are people on transplant, they have to be on medication to go through a safe pregnancy. Ultrasound and MRI are safe in pregnancy. Radiation exposure with most X-ray, CT are within safe limit. And vaccination not only protects the mother, but it also provides passive immunity to the baby. So whatever vaccinations are advised during pregnancy, they are not harmful to the mother and not harmful to the baby. In fact, they give some protection by giving passive immunity to the baby. And my last slide. So I would just like to say that a sick mother does not produce a healthy baby. So please do not refrain from prescribing essential medication to a mother who really needs it. We do not need to unnecessarily prescribe drugs. That is just as important. And we need to prescribe drugs when a mother needs it. So we need to strike a balance, and prescribing should be judicious, keeping both the mother and the baby interest in view. Thank you very much. Thank you for your patient listening. If there are any questions, I am happy to take them. Thank you.
Good evening, ma'am. Maruti here.
Hi, Maruti.
Ma'am, if we do have to prescribe progesterones, is there a safety limit dose, or the way we are giving after IVF and all that? Is there any particular dose at which we should stop?
No, there is no dose. But I can tell you, Maruti, people are just prescribing progesterone so indiscriminately. I don't think there is a risk of teratogenesis, because if we are using, micronized progesterone, and so these are probably not do not cause any teratogenesis. But in my own experience, I have seen cholestasis of pregnancy rising tremendously, many-fold, occurring much earlier in pregnancy, and very severe cholestasis. And that is one example. And there might be other problems that we may be creating iatrogenically because of giving progesterone, giving totally injudiciously. The question is, can I just say something?
Yes.
The question is not whether it can harm. There is also a question. If it is not doing any good, why do you prescribe any medicine to a pregnant woman? I would say even to a non-pregnant patient, why can't we be more scientific and prescribe medicine which we know is going to benefit, and just not for the sake of, like a placebo effect, or just because patient is complaining, we have to give some medication. We do not need to feel compelled to give medication just for satisfaction. Yes.
Thank you, ma'am. One more question, ma'am. Between the progesterones, which one should we prefer?
Like I said, natural progesterones are always preferable. So we usually give natural progesterones like vaginal and injectable. These are natural progesterones, or you can give micronized progesterone. So these are closest to the natural progesterone in the body.
Okay. Thank you, ma'am.
What about rabies? Some questions there. What about the rabies vaccine?
What about the
rabies vaccine?
Rabies vaccine, yeah, I thought I would write, but then but rabies vaccine, if it is required, must be given. If you
what about ranitidine tablet, madam?
Sorry?
Ranitidine tablet in pregnancy.
Ranitidine?
Yeah.
Yeah, ranitidine, there have been some questions recently, and although we have used ranitidine for very long time, and I'm not too sure whether many times it happens that you find something in literature and there is a lot of scare and the drug is withdrawn, and after some time the drug comes back. So I really don't think ranitidine is a big scare, but as long as it is not completely in the clear, maybe you could avoid prescribing it and give more of these PPIs, the esomeprazole and all these.
What about anti-cancer drug, Madam Pregnancy? Anti-cancer drug.
Sorry?
Anti-cancer drugs in pregnancy.
Anti-cancer drugs. Well, anti-cancer drugs, when we come to anti-cancer drugs, you have to go through the list. But, you know, like if you have an ovarian cancer, people have given cisplatin and still have normal babies. So when it comes to cancer, it becomes a very different situation, because it is not just a question of fetal harm, it is also a question of major maternal harm. Can we actually avoid giving these drugs? But you have to look up for each drug. You know, there are different drugs. I just remember cisplatin because we have given cisplatin during pregnancy in a patient and the baby was fine. But you will have to check for every drug. Like doxorubicin causes heart problems. For every drug, you have to look up maternal as well as fetal harms or fetal effects, and then only can we decide. So I don't think I am really the best person to answer that question, that which anti-cancer drugs. I mean, if I have a patient, I will also look up and see which is safest.
What about hypoglycemic drugs?
Hypoglycemic drugs, you mean the OHAs? So metformin is now quite in the clear. Metformin we are giving in PCO patients and continuing also in women who have abnormal GTT. And in fact, in pregnant women with diabetes, there is a little controversy. The American College says that you should start insulin and stop metformin in pregnancy if you are giving it for diabetes control. The Royal College UK says metformin is completely safe and you can give metformin and continue metformin. So actually metformin has quite a safe record now. And because even inadvertently people have taken metformin in many patients. And there is another thing, you know, about OHAs besides metformin. There were quite a few studies on glibenclamide and some other one, these OHAs, which actually showed, in fact, there was a very nice article in Lancet, which was almost 10 years ago, which showed that probably the teratogenesis in diabetes is not because of the OHAs or the drugs, but it is because of the high sugar levels. And they showed that they gave glibenclamide it's not that they gave, it was an African publication where women did not have access to insulin. They continued to take glibenclamide and they did not find any increase in teratogenesis. So like insulin, of course, is safest, but if somebody has had taken oral hypoglycemics, it's not that much a cause of concern. What can give rise to malformation is more if her blood sugar is not controlled. So that is more important to counsel her. That is why we normally say patients with diabetes, hypertension should have a pre-pregnancy counseling so that they only get pregnant when their blood sugar is controlled. Because the first few weeks, you know, by the time they realize they're pregnant and they've already done their blood sugars are uncontrolled, they are going to have increased risk of malformations, whether you give OHA or insulin.
Sir, our friend Dr. Meera is on the line. Dr. Meera,
Good evening, Dr. Meera. I can see you.
Madam, आपने को unmute करो.
Madam, unmute करिए, madam.
Namaskar.
Namaskar. Renu, I was all through with you. I congratulate you for a wonderful presentation. And the way you presented, I think everybody have learned everything. It was a great presentation and such a mammoth presentation you have capsuled in such a beautiful framed form that everybody has understood. An important thing which I just wanted, there is nothing to add, Renu. But as you know, till 13th of May, we were not allowed to give COVID vaccination to our pregnant and lactating women. And I'm feeling a little elated that we have marched forward along with the FOXI and we have approached technical committee and our All India Institute of Medical Science friends have followed it. And the technical committee of 13 persons coagulative group we have compelled, and we have put data and statistics that yes, they are giving it in America, they are giving it in Europe, and they are getting the vaccine. So we are giving vaccine for one and we are treating two. And that is how on 13th of May, they have allowed it for lactating women. But thereafter, they have took another 1 month to go through our discussions and advocacy. And I was surprised that we were not persuading for first trimester, but they have added first trimester also, because they were telling that the teratogenesis to this is not that important, that you are using the mother and the baby at the top age, and that is how they have allowed it in the first trimester. You very nicely explained it, COVID vaccine, and vaccination is never complete in the today's world unless you mention COVID vaccination for lactating and pregnant women. We are happy that we are allowed all the 3 trimesters. So when the registration is done, the government of India has issued a guideline that you need not to mention pregnant or non-pregnant. So if you are pregnant, it's okay. It is in your record that you are pregnant. Otherwise, they are not going to contradict. If you are in 18 years age or 20 years age, in the same group, you will be given vaccination. That is very important thing for our practitioners present over here, that we are free to give it these days. Renu, I really appreciate the way you have presented. It was very nice, so nice of you. Regarding metformin, I totally agree with you. But these days, we are not pro-insulin, we are pro-metformin, telling that it can be given and continued up to the first trimester if we are treating a PCOS patient with metformin. So it can be continued. I agree with you. So once again, thank you very much, Renu. Wonderful presentation. And I'm honored to be a part of it. I'm sorry I could join late because another Foxy meeting was going on. But I have enjoyed your this thing very. And I will ask Neelam to put the lecture for all the members.
Yeah. Thank you, ma'am. Thank you so much. Compliment coming from you means a lot to me.
Oh, thank you very much.
Thank you, ma'am. You have given such a wonderful lecture. I think so many gynecologists and all our general practitioners will take some take-home message. Thank you, madam. Thank you.
लेकिन मैम मैं एक बात पूछना चाहती हूँ आपसे.
हाँ बताइए.
आप कह रहे हो ना कि उस पे मेंशन नहीं करते, मतलब वो बाकी सबके साथ प्रेग्नेंट लेडीज को वैक्सीनेट करें, वो तो कोई बात नहीं, दैट इज नॉट इशू.
Right.
But क्या वो मेंशन नहीं करते अपने उसमें डेटा में? बिकॉज एट द एंड ऑफ द डे हाउ विल वी नो?
They mention it. जैसे there is one column contraindicated. Earlier, if you agree, this serum vaccine, the Serum Institute, they have written it is strictly contraindicated.
वो तो जब तक गवर्नमेंट ने अलाउ नहीं किया था.
So up to 13th, maybe our letter reached on 7th, and up to 13th they were writing it is contraindicated. You see, the letter to the government of India, I have read it a day before. They were telling it, so company people were telling it is contraindicated in pregnancy and lactation. So once it was allowed, then government of India issued a letter telling that it is not contraindicated, it is rather indicated if you are pregnant.
Given actually. Right. नहीं, मैं कुछ और रीजन से पूछ रही थी. मैं कह रही थी कि जब तक वो डेटा कलेक्ट नहीं करेंगे कि कितने प्रेग्नेंट लेडीज में उन्होंने दी, तो बाद में उसको कैसे निकालेंगे कि भाई हाँ इतने लोगों को दी.
रेनू अपनी
वो लिख रहे हैं, वो
they are putting it for statistical purpose.
That's what I'm asking.
But they will not ask तुमने प्रेगनेंसी टेस्ट करा लिया है कि नहीं है,
उसकी जरूरत नहीं है,
और तुमने प्रेग्नेंट हो कि नहीं हो, और maybe that she doesn't know that she is pregnant and she must have got vaccination.
Yeah.
I'm sorry, I'll have to interrupt over here and tell you to please stop this discussion because we have another speaker who's not waiting for quite some time.
Thank you very much. Thank you very much once again, Renu.
I know we are very, very thankful. Such an excellent talk that you said. So thank you for this session and thank you, Dr. Kishan, for being the conductors for this session. Our final session for the day is now session which is going to be conducted by Dr. Gaurav Dubey. Speaker is Dr. Cyril Shaw. So Dr. Gaurav, please come forward and please.
Thank you, Dr. Bajwa. And it is a matter of great pleasure and honor to have with us Dr. Cyrus Shaw. And I apologize for the delay, sir. I'll start by who will be speaking on a very important topic, diabetic retinopathy, what the clinician must know. Dr. Cyrus has been practicing exclusively in the field of ophthalmology and vitreoretinal medicine and surgery for about 34 years now. He's the medical director of Shop Eye Center at Kailash Colony, New Delhi. He's also a member of the Board of Trustees and the senior consultant and advisor to Dr. Shroff's Charity Eye Hospital. Dr. Cyrus was the president of Delhi Ophthalmological Society from in April 2015 to 2016. He was the president of Vitreoretinal Society of India for 2 years and the secretary of Vitreoretinal Society of India for 2 years again. He was also the honorary ophthalmic surgeon, the president of India from 1997 to 2002. He has the privilege of carrying on a 100-year-old tradition of eye care in the city of Delhi, which was started by his grandfather, Dr. S.P. Shroff, in 1914. And he was among the first in North India to perform vitreoretinal surgery and pioneered and propagated the concept of true bimanual vitrectomy. He has participated and presented papers, conducted sessions in numerous international meetings, national meetings. He has been awarded many awards and citations in various peer-reviewed journals, and he's very well known all over the world for his work in vitreoretina. Dr. Cyrus has also been a mentor to many of budding young vitreoretinal surgeons and enjoys working with his young committed team. I now request my chairman, Dr. Avad Dubey, to say a few words and then we'll start with the presentation.
Thank you, Doctor. I don't know whether I'm visible on the screen, but if I am audible, then it's
yes,
fine.
you're audible.
It's a matter of great privilege and joy for the city of Kanpur to have amongst us one of the best friend Kanpur ophthalmology has ever got across the globe. Dr. Cyrus needs no introduction, otherwise it has also been given by Dr. Gaurav. I would just add that he is one of the finest persons and very close friend of mine, and it gives me immense pleasure to talk to him. So if I talk about him, it will take hours and hours together. So with these few words, Dr. Cyrus, you are welcome again in some way to Kanpur, and we request you that whenever the time permits, you will give us an audience. The and also will serve the dishes was live and to Kanpur. So thank you very much, and thank you to the audience, the organizers, who also diabetic seat.
Thank you, Dr. Avad Dubey. Thank you so much for your kind words, and Gaurav for your very kind introduction. It's thank you very much for this invitation to the IMA College of General Practitioners, the Kanpur faculty. It's a pleasure and a privilege to be here this evening, and I'll be speaking to you briefly about diabetic retinopathy with a special focus on the recent advances and what physicians and general practitioners should know about this condition. Should I start sharing screen?
Yes, sir. Yes, sir. Yes, sir.
So in the next few minutes, this is the topic we'll be talking about. These are my financial disclosures. One thing right at the beginning is about the lack of awareness about patients about retinopathy when they have diabetes. And that is one of the main reasons that they often lose vision, is because of this lack of awareness. Thus, it is essential for physicians and ophthalmologists to recognize the importance of diagnosing and treating this disease early. The pertinence, and here is where the importance again comes in. I think all physicians, and nowadays I have noticed over the last few years, there has been a marked change now. Earlier, many patients used to come with advanced disease and they never knew the fact that they would possibly could lose vision because of diabetes. But now I think there is an increased awareness coming up and they are much more informed about their eye condition when they come to us. Diabetes is extremely common in India. It's an important cause of blindness in the working age group. Even now, a third or a fourth of them never know about the disease, and blindness due to diabetes, important thing is it is preventable in most cases. Diabetic retinopathy is a leading cause of vision loss globally. Of an estimated 285 million people with diabetes mellitus worldwide, approximately 1/3 which ultimately show signs of diabetic retinopathy. And of these, a further 1/3 can have vision-threatening diabetic retinopathy, including diabetic macular edema. So the number of people with diabetes mellitus is expected to rise to 370 million by 2030, which is a WHO prediction. And of these, India would have almost 80 million. So this is a little illustration about this fact about worldwide 171 million in 2000. By 2030, this would rise to 366 million. And India from 31.7 million to almost 80 million in 2030, which is a huge number. This is again another projection which takes us a little beyond that, even to 2040. And so by that time, adults living with diabetes would be about 642 million, and 35% or 225 million would have some form of diabetic retinopathy, and almost 70 million have vision-threatening diabetic retinopathy. So you see what a huge public health problem also this is going to be, and would require a combined effort of physicians, ophthalmologists, healthcare workers, and the administrative machinery in most public health systems to be able to cope with this huge problem. From the 17th most common cause of blindness, now diabetic retinopathy has become the 6th most common cause of blindness worldwide. I won't go into the details about this, but there have been Indian studies also about the diabetic retinopathy prevalence. And in the Wisconsin epidemiological study, they found that a 25-year study they did, and the cumulative incidence of DME, that is diabetic macular edema, seemed to plateau at the 14-year mark. Diabetes, macular edema in 26.1%, and clinically significant macular edema in 17%. At 25 years, again, we see that the figure is not too different. From 26, it's only risen to 29%, and clinically significant macular edema is still only about 17%. And this supports the conventional wisdom or opinion, and this is also an observation which most of us have, that if a patient has no retinopathy at 15 years of diabetes mellitus, he is unlikely to develop it subsequently. Coming on now to the classification of diabetic retinopathy. So typically it starts with a non-proliferative diabetic retinopathy, which can later progress on to proliferative retinopathy, which is relatively early in the type 1 diabetics, so the younger diabetics. And in the type 2 diabetics, maculopathy is what we see relatively earlier. However, subsequently in later years, the proliferative also develops maculopathy, and people with maculopathy can develop proliferative diabetic retinopathy, which is hemorrhage and other complications. And then going on, if not attended to in time and early, going on to advanced diabetic eye disease, which we'll see a little later, like traction detachments and vitreous hemorrhage and neovascular glaucoma. Non-proliferative diabetic retinopathy are microvascular changes which are limited to the confines of the retina, what we know typically as macular edema or hard exudates. And proliferative diabetic retinopathy is growth and extension of the new vessels beyond the internal limiting membrane of the retina into the vitreous cavity, leading on to vitreous hemorrhage and other problems. Non-proliferative can again be classified into mild, moderate, and severe, and proliferative diabetic retinopathy into early or high risk of vitreous hemorrhage. Recently, in a lot of the studies which have been done and trials related to diabetic retinopathy and diabetic macular edema, the concept of center involving macular edema and non-center involving macular edema is something that is being used very often. And the reason being that the vision gets affected when the macular edema involves the center of the macula or the fovea. Another important thing, again, for all of us to know is what should be the timing of the initial dilated fundus examination. So if the age at the onset of diabetes in the younger age group, the first examination should be performed by 5 years of onset. Ideally, of course, whenever detected, but it's important that within 5 years of onset, the retina should be carefully screened. In the older age group, then it's important to know when the diagnosis is made, because very often we don't know when the actual date of onset is. So they may have actually already had diabetes for many years when they are diagnosed. In pregnancy, we have to be especially careful, and during the first trimester itself, they should have a fundus examination and also follow up in the second and third trimesters. What does the clinical examination entail? It is a biomicroscopy. There's a slit lamp anterior segment examination and a slit lamp examination with a 78 or 90 diopter lens, which gives you a magnified view of the posterior pole and macula. Indirect ophthalmoscopy and red-free ophthalmoscopy. Red-free, even with a direct ophthalmoscope, you can picks up new vessels and vascular abnormalities on the retina much more quickly, and it shows up much better than the white light or yellow light. Fundus fluorescein angiography is an investigation which is used to image the retinal vasculature. It guides the treatment of macular edema, delineates subtle neovascularization, and we can view the macular ischemia in this area. It would tell us whether it's well perfused or not. Optical coherence tomography is something which has completely revolutionized the diagnosis and the management of diabetic retinopathy, especially the macular edema, and also in many situations in proliferative diabetic retinopathy, because it gives an in vivo histology like anatomical structural details. So you will have a virtual cross section of the retina and all its layers, and up to a less than 10 microns resolution. It's also useful for guiding the quantification and treatment of macular edema and tracking the response. So nowadays, especially as we'll see later with the use of anti-VEGFs for macular edema, OCT is a completely non-invasive investigation which can be repeated virtually every time the patient comes, and you can track what is the progress, whether it's macular edema is stable, worsening, improving, and all this can be done very quickly and without needing to inject any dye in the system. Fluorescein angiography, again, the indications are macular ischemia or leaking microaneurysm around the fovea, as we see here, in clinically significant macular edema. There is some enlargement of the foveal avascular zone that shows that early ischemia is setting in. It shows us the areas of non-perfusion. This shows that these areas are suffering from non-perfusion. So we are careful that these are the eyes which may go into proliferative retinopathy, and in severe cases of non-perfusion, also the risk of developing iris neovascularization, neovascular glaucoma. Here now we see this new vessels on the disc and elsewhere, the ones which are leaking the dye. And you can have intraretinal microvascular anomalies here like this, which are seen on the angiography but don't leak dye. It detects subtle neovascularization in cases with media opacity. Example, here we see a patient with asteroid hyalosis in the vitreous cavity, where you get a poor view of the fundus on indirect or color photograph, but on the fluorescein angiography, it shows very clearly, and you see that this patient is already having a proliferative diabetic retinopathy and needs intervention with laser and maybe also with anti-VEGF agents. Now the treatment, what are the basic treatment options in diabetic retinopathy? One is good metabolic control. This is very important because it has been now well established that poor metabolic control can lead to early onset of diabetic retinopathy and worsening of existing diabetic retinopathy. Laser photocoagulation, steroids, intravitreal or subtenons, anti-VEGF agents, as we'll see in detail later, and in some of the more advanced cases, pars plana vitrectomy. Good metabolic control can retard the progression of diabetic retinopathy and even reverse some changes, especially macular edema and hard exudates. These are the things which need to be monitored very carefully: glycosylated hemoglobin, serum lipids, renal functions, hypertension, anemia. And nowadays we've recognized this history in many cases where there is refractory or recalcitrant macular edema which is not resolving. Pioglitazones are known to aggravate some cases of macular edema. So it's important to take this history and make sure that the patient is not on this genre of drugs. Maculopathy, again, as we see, can be either macular edema, which can be focal or diffuse, or it can be ischemic, where there's a loss of the capillaries in the fovea itself, which has a relatively worse prognosis. And it can be a mix of both ischemic and of macular edema. Macular edema is called clinically significant when there is retinal thickening at or within 500 microns of the center of the macula, when again it becomes vision threatening as well. This can occur at any stage of diabetic retinopathy. It occurs in 10% of all patients of diabetic retinopathy and 3% of eyes with mild and non-proliferative diabetic retinopathy. And the incidence increases as you go on to severe non-proliferative or proliferative diabetic retinopathy. Here we see on the OCT scan, the patient having thickening of the retina. These areas, there is macular edema, and also there is some fluid underneath the retina, what we call neurosensory fluid or neurosensory detachment in this localized area. Laser photocoagulation was the first treatment for diabetic macular edema, and only 17% of patients had improvement in vision, and only 3% had more than 3 lines of improvement. And there was progressive loss of vision in up to 26% of vision despite laser treatment in the early treatment diabetic retinopathy study. And the results were even more dismal when we talk of diffuse macular edema. This is again an OCT showing a response to laser treatment. Here the patient has responded well, and we see from the macular edema here, they have a relatively dry macula. This dip which you see here is the fovea. This again is an OCT pre and post laser showing some improvement because of changes in the outer retina layers, sometimes the vision doesn't improve even when the macular edema comes down. The advent of anti-VEGF agents was quite a revolution in the management of diabetic macular edema. Poor results with laser, especially in diffuse macular edema, led to a search for pharmacotherapeutic agents to treat this condition. Very promising results in age-related macular degeneration, for which these anti-VEGF agents were first used, led to trials for DME and other causes of macular edema. And these agents have now revolutionized management of DME and been a great boon to patients and a great help to us as caregivers. Anti-VEGF agents act in multiple ways as an anti-angiogenic factor, that they prevent the formation of new vessels or proliferative retinopathy, also as an anti-permeability factor, that is, they reduce the leaky tendency of the capillaries, so cut down the macular edema, and also have an anti-inflammatory action. Now, the available agents which we have as of now are Avastin or bevacizumab, which was initially a drug used in cancer, for colorectal cancer, but now widely used for the management of macular edema. Of course, it is still off-label use, but it is the least expensive. And in our country, especially, a lot of patients do benefit by treatment with this agent. The other ones are Lucentis or its Indian biosimilar Razumab, which is ranibizumab, aflibercept or Eylea, and very recently Novartis introduced this brolucizumab or Paginex, which apparently, although it's a similar mode of action, has a longer duration of action and so possibly would need lesser frequency of injection. Where again we see Avastin pre and post injection, we see the marked reduction in macular edema. But again, these injections have a finite period in which they are acting, so they can, after some time, the edema tends to recur. We see pre-injection, 2 months post-injection, we have a dry fovea and macula, and 4 months post-injection, we find there's a rebound and again an increase, so the patient will require a repeat injection. This is post laser treatment and the use of intravitreal triamcinolone. This is pre and post the treatment. We find there is a marked reduction in the exudates also, and the OCT shows a dry retina. This is again pre-laser and intravitreal steroids, and this is post the laser steroid. Again, because of these heaping up of the cells and changes in the outer retina, we find that the visual result may not be sort of commensurate with the amount of improvement we see on the OCT. Dexamethasone, now we know that this is also helpful, especially in cases where the inflammatory component is supposed to be more in some of these situations, and the Dex implant works very well. The duration of action is also relatively longer in this. Compared to the use of triamcinolone, the cataract intraocular pressure rise appears to be much less than with triamcinolone, and this has also been a promising addition in the armamentarium for management of macular edema and diabetes, especially the diffuse type. Here we again see post 2 anti-VEGF injections, there is still a lot of macular edema. It has not resolved. And post Dex implant or this intravitreal steroid pellet, the macular edema is showing a marked reduction, and also the visual acuity of the patient has improved. Now, coming to the role of steroids, usually intravitreal steroids are not the first line of treatment, especially keeping in view the fact that the side effects, which we'll just see a little later. However, if there is a poor response or no response to anti-VEGF agents, or a very transient response when the anti-VEGF injections are required very, very frequently, say in even less than a month, it tends to come back, then steroids are useful. Also an important indication when anti-VEGFs are contraindicated. In patients who have vascular conditions like unstable angina or a recent MI or recent stroke, anti-VEGF injections are contraindicated. And in those situations, again, the steroid is much safer for these patients. We often refer to these patients before giving an anti-VEGF injections to physicians or the cardiologist for clearance before injecting anti-VEGFs if there's any doubt regarding their systemic status. Steroids, because the most important contraindication is glaucoma, because there can be a further rise in intraocular pressure, and that most of the times can be managed with anti-glaucoma drops, but sometimes the patient may even require surgery. Cataract can develop over a period of time, especially if repeated injections of steroids are required. But this is a relatively simple problem and can be taken care of with cataract surgery. So again, coming back to the various modalities of treatment, we've seen about the good metabolic control, laser photocoagulations, steroids, intravitreal and subtenon and anti-VEGF agents. So for To summing it up, a focal type of macular edema, good metabolic control and laser photocoagulation works well. The OCT is useful in tracking the response, and repeat laser we do at 4 months if it tends to persist. So this was a case here. We see it's a relatively localized macular edema. Here it begins to threaten the macula. We don't want it tracking into the fovea, and the patient received laser treatment, and that leads to resolution of the macular edema. In diffuse macular edema, good metabolic control is extremely important. Here, during laser photocoagulation should be done only after the edema has regressed significantly, because when there is a lot of edema, the laser power that has to be used is higher, and early and aggressive laser can cause hard exudates to deposit in the fovea with irreversible vision loss. This is a condition we see with diffuse macular edema. So nowadays we would not go in and directly do laser in these situations. Here we see this diffuse leakage on the fluorescein angiography. So these should be first treated with anti-VEGF agents, and either continuing that, or in some situations, if there are discrete microaneurysms, we treat that with laser to prevent the recurrence of macular edema. Coming on now to the role of vitrectomy or surgery for diabetic macular edema, there's a definite role only when there is associated traction over the macula. In those cases, sometimes the anti-VEGF agents also are not very effective, or the edema tends to come back very rapidly. And in those cases, sometimes the vitrectomy and removal of the traction helps to resolve the problem. This is pre-vitrectomy for diabetic macular edema, and this we see is post-vitrectomy. This is another case, vitrectomy plus ER removal and anti-VEGF for this was for a proliferative diabetic retinopathy, but also having macular edema, very significant macular edema and neurosensory detachment. And here we find that after the surgery, the edema has gone away and we find a almost normal looking OCT. When the maculopathy is ischemic, there is a perfusion is not there in the macula at all, then the prognosis is not good at all. And metabolic control may arrest deterioration. And if there is concomitant macular edema or proliferative disease, then that has to be treated on its own merits. So here we see another case, here the color photograph, and here on the fluorescein angiogram, we see there is a complete loss of capillaries here in the fovea. And here in this condition, in a situation like this, the prognosis for vision or central vision improvement is markedly compromised. Coming on to proliferative diabetic retinopathy, laser photocoagulation is still the gold standard for these cases. Anti-VEGFs and steroids are often helpful adjuncts. Vitrectomy is required if not controlled despite good laser. And early vitrectomy is often done in situations like very severe fibrovascular proliferation or dense premacular hemorrhage. So here we see now this is a fluorescein angiogram showing disc new vessels and new vessels elsewhere. So we are dealing with a full-blown proliferative diabetic retinopathy. This area shows a lot of non-perfusion of the retina. And these are the laser marks received to do a pan-retinal photocoagulation. This is a patient again who's having had laser but still has persistent new vessels. And we've done further focal photocoagulation to that area, and then the new vessels tend to regress. This is again new vessels here, and after further laser and anti-VEGF agent, we see the new vessels have stopped leaking. This is just another mode of delivery where the Pascal, this semi-automated pattern generation technique allows rapid delivery of the laser in predetermined sequences. This is another case of proliferative diabetic retinopathy. This is the fluorescein angiogram pre-laser, post-laser. It has improved. We see the leakage is less, but there are some leaking areas still persisting, new vessels persisting. Here again, after extensive laser, still new vessels are persisting. And after Avastin, in these situations, sometimes giving an additional anti-VEGF, the leakage goes away. So in this situation in which anti-VEGF agents have a role in proliferative retinopathy as well. So the role of Avastin, or I would say generically anti-VEGFs in PDR, is active new vessels despite maximal laser, but not, we avoid this if there's a significant tractional element, because that can sometimes be aggravated by the anti-VEGF agents. Pre-PRP, especially if the new vessels are severe. Pre-vitrectomy, we often give these agents if there is very florid and active neovascularization, because that tends to reduce the chances of bleeding during surgery and gives better result. And also sometimes for post-vitrectomy rebleeds. Now, just a little short thing on the vitrectomy for diabetic retinopathy. The classical indications are traction macular detachment, vitreous hemorrhage, and traction rhegmatogenous or a combined retinal detachment. Newer indications are progressive fulminant neovascularization. If you see a very severe PDR, which you know is not going to respond to laser, or the traction might increase despite laser, then we do what is called an early vitrectomy in these situations. If there's a dense hemorrhage in front of the macula, we shouldn't leave it there too long, or progressive macular traction or a traction detachment threatening the macula, or diabetic macular edema with vitreous traction, as we saw a little while back, an example in tractional macular edema. So these are some of the cases where vitrectomy is required. Here you see this is relatively inactive, but this dense sheet of hyaloid in front of the macular area itself. So this needs to be cleared to be able to improve the vision. Here you see this proliferation over the retina and hemorrhage covering the macula. So that requires a vitrectomy to remove this blood and restore good vision for this patient. This is a case with severe active neovascularization, and we know that despite PRP, this is not going to regress and probably is going to in fact threaten the macula and cause more traction. And once the macular function becomes poor, that doesn't come back even after surgery. So it's better to do early surgery for these cases. The decision for surgery is always based on these factors: existing vision, visual needs of the patient, a risk-benefit ratio, systemic status, and life expectancy of the patient. Nowadays, with advances in instrumentation and greater experience of operating these cases, early vitrectomy is advised, and better anatomical and functional results can be achieved with early intervention, because the retina and especially the macula is still healthy. And in this case, if you can operate on a healthy macula and achieve reattachment and stability, then these patients can sometimes have very good vision. These are some of the contraindications: absence of light perception, advanced rubeosis with neovascular glaucoma, on old macular detachment with absolutely atrophic retina. So these are some of the situations in which surgery is avoided. Thank you very much for your attention. So we could take any questions or discussion now. There's one comment by Dr. Agarwal about if we can be helped by fundus photography by handheld non-mediatic cameras. Definitely, that's a good thing, especially for screening, and this can be a useful tool, and it can tell us which patients require to be then seen subsequently and have an intervention with a retina specialist. So definitely, I think diabetic retinopathy screening is the most important thing. And nowadays, of course, there's a lot of work on artificial intelligence now coming in a big way for this, because we have built up algorithms where if you have a fundus image, the software analyzes it and tells you what is the chance that this person needs or the retinopathy is going to progress or needs intervention by a diabetic, by a retina specialist. So I think now gradually this is going to be something which is going to become very important. And the day may not be far when you may have these screening devices, even with, they are already there with opticians, setups, optometrists. And nowadays they say even when you visit a mall, maybe you can have a fundus photograph, and that could be read by artificial intelligence, and the patient told whether he needs to go further for a more detailed examination and treatment.
Sir, good evening, sir.
Good evening. Good evening.
This is I was Dr. Agarwal. I asked that question,
Yeah.
and one more question, sir. How long can we give these VGF injections intraocular? I mean, if as a medical specialist in CGHS,
yes,
we see many patients are being prescribed these injections very often. How often can be given, for how long actually? Any study like that?
No, there's no kind of a time limit to this thing for it. It depends on the need of the patient. There are patients who, with after a couple of injections, the edema just goes away, and then you follow them up, and it never recurs. And they in the meantime established good metabolic control. There are other patients who, despite the best possible metabolic control, they are very diligent. They keep their diabetes extremely well controlled, and yet the edema keeps coming back every month or 6 weeks or 2 months, and then they require repeat intravitreal injections. So that's something, and there's no limit. I mean, if a patient, important thing is two things. One is they should be responding to it. If a patient responds and is maintaining good vision, then, and if his vision drops once the effect of the anti-VEGF has gone away, then they need repeated injections. So there are patients who may have had more than 40, 50, 60 injections, but as long as they are maintaining good vision, and many times some of these patients are, they are maintaining good vision in their better eye, and the other eye has already reached a stage where they're not going to be helped by any treatment. So I think in those cases, especially, it's extremely important for the injections to keep continuing. The other thing is, when you stop is when it reaches, for example, if there is marked scarring there, or if there's total atrophy of the photoreceptors, and you find that there's injection is not helping at all, even if it brings down the macular edema, the vision just stays the same because the photoreceptors have become totally destroyed, then we stop injecting, because then there's really no point in giving them further injections.
Thank you very much, sir. Thank you very much, sir.
Gaurav, anything? Dr. Awad, are you online?
Sir, can you hear me now?
I can hear you now, Gaurav. Yeah.
Okay. Sir, I was asking that since there's some physicians also attending, so what is your experience and opinion regarding the progress of diabetic retinopathy in association with, say, diabetic nephropathy or a neuropathy? Can they have a idea about if the patient is progressing with a kidney disease or the neuropathy? And can they sort of predict how the retinopathy is progressing?
No, I think as far as linking is concerned, every patient of diabetes, even if they don't have those comorbidities, should have a regular fundus examination. But definitely, if a patient has nephropathy, then their risk of developing or having diabetic retinopathy is much higher. So they would definitely need to be referred to an ophthalmologist, at least, who is well versed with fundus examination, or a retina specialist, to see whether they have concomitant. Because the important thing with or the sort of disturbing thing with proliferative diabetic retinopathy especially is that patient may have no symptoms. The patient is developing very severe neovascularization, but if the macula is okay, they have 6.665 vision. And it's only when they develop a bleed that you would get to know that they have this retinopathy. So I think that is where the importance of the screening or the regular checkup comes in, to make sure that they are not developing something like this that is like a time bomb which can go off anytime. As far as neuropathy is concerned, I don't think there is a very definite correlation as such with this, but nephropathy, there is a very definite correlation with more severe retinal disease.
Thank you, sir, for a wonderful and informative talk. And we're sorry for the delay which was caused.
No,
it
no,
was
no.
always a pleasure to have you with us. And I now hand over the mic to Dr. Rajneesh Bajwa, who's the Assistant Secretary.
Thank you, Gaurav. Thanks a lot.
Thank you so much.